its speed. It should move at the rate of 25 millimeters per second. So when it moves 25 millimeters per second, this box 5, it means it takes 0.2 seconds. And 0.2 seconds means each small box is 0.04 seconds. That is how you get to know. So why you need all this information? Because when you get a waveform, you need to calculate what is the P wave duration, what is the PR interval, what is the QRS, what's the ST segment, what is the duration of the T wave, all those things you need. And for that, the time measurement is through those boxes. Each small box is 0.04 seconds and one box is 0.2 seconds. Right? Now, before the ECG was taken, we used to press one button multiple times and the stylus used to go up, down, up, down, up, down. And then we used to look at it and say, yeah, now I can do an ECG. Now what is that? Every time you press the button, you are giving a 1 millivolt current. So when you give 1 millivolt current to the ECG machine, the writer or the amplitude of excursion by the writing apparatus should be 10 millimeters. So this one box is 0.5 millimeters. So it should be 1. So it should be probably 1 millivolt should be equivalent to 10 millimeters. Here it is 5 millimeters. 1, 2, 3, 4, 5. So one large box is 0.5. But in your ECG machine, once you give 1 millivolt, the amplitude of movement vertically should be 10 millimeters. So a standardized ECG machine means it is moving at a rate of 25 millimeters per second, the ECG paper horizontal. And the vertical deflection is for every 1 millivolt current, the deflection 10 millimeters. Is this clear? When you give 1 millivolt current, the deflection should be 10 millimeters. And the writing speed should be such that the paper moves at a rate of 25 millimeters per second. And this is how a normal ECG looks like. It's a standard 12-lead ECG, lead 1, lead 2, lead AVR, AVL, AVF. The first 3 are bipolar leads, then the remaining all are unipolar leads. AVR, AVL, AVF is unipolar limb lead, 1 to V6 is unipolar test lead. Now, one simple question. Can you read this ECG? You should not read this ECG. Why you should not read this ECG? Because purposefully, I have not shown you the standardization. But then, if you look carefully, this is a computerized ECG. There is a standardization. Can you see one vertical bar? Between 1 and AVR, one line is there? That is standardizing. It means that the standardization is appropriate. This is how a normal ECG looks like. You have the P wave, then you have the QRS complex, you have the S wave merging into the ST segment called the isoelectric ST line, the T wave and the U wave. 1 minute, I think I'll make use of a pointer here. Now I think it's better. So this is the P wave, the Q wave, the R respect to this isoelectrical line, respect to this isoelectrical line. Can you see that? It's okay. It's okay. I'm able to do it. So this is called the isoelectric line. So the P wave followed by a negative Q, a positive R, then the down part. See, it should stop here. This is the Q. This is the R. R stops here. This is negative. Yes. Isoelectric. Positive T and a positive U. That's how you look at it. So it is with reference to this line. Again, P, electrical quiescence, negative Q, R, stop, Then there is a negative here. Yes. Isoelectric line. E. U. This is how you look at it. Now, why do you use waves? The P wave is because of depolarization of the atria muscle is getting depolarized. Q, R, yes, this complex, the initial Q, positive R, negative yes. It's all because of depolarization of the ventricle. The T wave is because of repolarization of the ventricle. So depolarization of the atria, depolarization of the ventricle, repolarization of the ventricle. Something is missing here. Where is the depolarization of what? Repolarization of atria is missing. This is depolarization of ventricle, repolarization of ventricle. Okay, this too belongs to ventricle. This is depolarization of atria. There is repolarization of atria. What happened to that wave? The repolarization of atria happens when this is happening. The QRS is happening. That is depolarization of the ventricle is happening. So the repolarization of the atria, the wave that is produced, is hidden within the QRS complex. How do you know that? You know that when you do intracardiac electrograms. You know, you put some wires inside the heart and study the electrophysiology. You know, when you do EP study, you call it as electrophysiological study. So when you do that, you will be able to identify, and that is why it's very important to spend time on the ECG. So you get the P wave duration, PR segment, QRS duration, ST segment, PR interval, RR interval. RR interval means every time one time the ventricle contracts is represented by an R. So you can see how much is the heart rate. If you measure the RR interval, you can calculate the heart rate. Not only the heart rate, you can identify so many things on the E. So for beginners, it's important that you have a method. You have an important method. First of all, as soon as you take the ECG, look whether there is standardization or not. Once you know if there is a standardization, you look at the rhythm. Is it regular? Not regular. Rhythm, heart rate, PR interval, AV conduction. You know the format. QRS interval, QT interval, mean QRS, electrical axis. Electrical axis, yeah, I know everybody is scared of electrical axis. I'll make it simple, don't worry. T wave, QRS voltage, precordial R wave progression, abnormal Q waves, segment T waves, U waves. So once you look at the ECG, all these things you should be systematically looking at. Never be in a hurry to read an ECG. You'll be missing something. No two ECGs are similar. Please remember this. Just like no two patients are similar. So in the same way, no two ECGs are similar. So be very careful, and it's not difficult. You have to spend time. You have to spend your energy on it. You have to sit with it. You have to count the number of squares. You have to look for abnormalities. Only by doing that, you are going to become proficient in reading ECG. So this is what is the standardization. I already explained this. I've told you that the ECG moves at 25 millimeters per second. And for every 1 millivolt, it is 10 millimeters. So instead of saying 0.1 millivolt per millimeter, I put it in a different way. Every time you give 1 millivolts stimulus, there should be a deflection of 10 millimeter. So this is how a standardization looks like. This is normal. See, 1 millivolt was given. So what's the number of boxes here? 5 plus 5, 10. Can you see that? This ECG paper is moving at a rate of 25 millimeters per second, and somebody has given 1 millivolt current to this. So the baseline is this, and the stylus has gone up by 10 millimeter. 5. Sometimes the voltage of the ECG is so high, the heart would have become very big. There will be chamber hypertrophy. So the voltage is more, and when you're doing your ECG, your graph, the QRS, the QR wave will be going beyond the paper. You won't know till where it is going. So you want to reduce the standardization. So what you will do is, for every 1 millivolt, you will say, I want only 5 millimeter deflection or 0.5 mm. What you will do is, you will call it as half standardization. That is 5 millimeter per millivolt. Sometimes when you do an ECG, especially in women who are very obese, the QRS is so small, you will not be able to see the P wave fully, you will not be able to see the QRS fully, so you want it to be magnified. So what you will tell the machine, take the standardization, for every millivolt that you express, make the amplitude 20, not 10. So that is called as double standardization. So this is 20 millimeter, right? Per millivolt, it will move 20 millimeter. This is called double standardization. So did you know, we make, this is the standard. All our, if you don't tell anything to anybody and ask them to record an ECG, this is how it is. This is half, this is double. So evaluate, now next is looking at the rhythm. Evaluate the rhythm strip at the bottom of the 12-lead ECG for the following. Is the rhythm regular or irregular? Obviously it looks very regular, isn't it? Is there a P wave before every QRS complex? This is the P wave, QRS, wave, QRS. Let's come up, QRS, QRS. So there is a P wave behind every QRS. Are there any abnormal beats? This ECG obviously does not show any abnormal beats. It shows a P wave, a QRS, a T wave, a P wave, a QRS, a T wave. So this is coming regularly. Therefore, it is a regular rhythm. So you will call this as regular rhythm. Now coming to the heart rate. By looking at the ECG, can you estimate the heart rate? Yes. There is something called rule of 300 or 1500, or second way is 10-second rule. It looks very difficult. Actually not. What you have to do is just count the number of big boxes between two QRS complexes and divide this into 300. Or the smaller boxes by 1500. You can keep any one of them. Normally what I do is, I remember this 1500. If you want, you remember it as 300. Whichever you feel comfortable. If it is 300, count the number of big boxes and divide. If it is 1500, they are the small boxes. Now, for example, what is this rule of 300? See, there is a R wave here. There is a R wave here. How many big boxes? 1, 2, 3, 4, 5, 6. 300 by 6 is, heart rate is 50 beats per minute. So if somebody gives you this ECG and says, tell me, what is the heart rate in this patient? Look at the ECG and tell me. You will say 50. Got it? What did you do? You counted the number of big squares. 1, 2, 3, 4, 5, and 6. So the heart rate is 50. Here, what is the heart rate? You can see one R wave here, one R wave here. How many boxes? 1, 2, 3, 4. If you count from here to here, that becomes one box. So 1, 2, 3 plus one box. So 300 by 4 is approximately 75. What is the heart rate here? Now look at this. This is ventricular tachycardia, VT. It doesn't show QRS. It just shows some broad complex QRS, negative, and it is coming regularly. And if you look at the number of boxes between this and this, hardly 1.5 boxes. From here to here. So divide 300 by 1.5, the rate is 200 per beats per minute, right? There is also something called as 10-second rule. That is, count the number of beats present on the ECG during 10 seconds, that is 50 big squares, and multiply them by 6. For example, this ECG. So from here to here, count the number of complexes. You have 33 complexes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, and then you come up to 33. And this you multiply by 6 and you get the rate as 198. So there are various ways of trying to calculate the heart rate. Now, normal ECG, this is something all of you, if you're writing your exams, or all of you who want to understand about the ECG should know, no excuse. PR interval duration 0.12 to 0.2. So P wave duration should be not more than 120 milliseconds. So these are all these important points you have to know. You write it down somewhere, every day go and see, put it on your wardrobe, take a printout of this, put it somewhere. You have to know this. There is no excuse. And by repeatedly seeing the ECGs every day, you look at ECGs, try to calculate and see, is the PR interval okay for this ECG? Is the PR interval, take 5 ECGs, calculate PR interval, and then you will know, is it coming within 0.12 to 0.2 seconds. So here, the P wave duration should be less than 120. Now, what is this less than 120 milliseconds? What is this 120? 120 means 0.04. Each box is 0.04 seconds. So 3 boxes. 3 boxes will be 120. So the duration of the P wave in your ECG paper should not exceed 3 boxes. That's all. Is it difficult? Instead of remembering it as 120, best thing is look at the duration of the P wave, see if it is less than 3 boxes or more than 3 boxes. If it is more than 3 boxes, it is abnormal. Prolonged. Is less than 3 boxes, it is normal. That's all. PR interval 0.12 to 0.2 seconds, 4 squares. What is 0.2 means 5 squares. 0.04 into 5 is 0.2. That's all. So see if it is less than 5 squares, 5 boxes. Isn't it? So it's all about application, how you apply your mind. So QRS duration is less than 120 milliseconds. So it should be 110, 0.04 plus 0.04 is 0.08 plus 0.04 is 0.11 to 12. So it should be less than that. If it goes beyond that, you call it as wide QRL. Simple, isn't it? So QT interval also, in the same way, you will diagnose T interval also, 440 milliseconds. It should be 440 milliseconds and less in males, 460 milliseconds and less in males. We'll come to that. So PR interval is atrial depolarization plus delay in AV junction, that is AV node and bundle of phase. So what is this PR interval? P wave, you know, is the atrial depolarization. Then until it joins the Q wave, there is a flat line, isoelectric line. What does that isoelectric line represent? It represents the current traveling through the AV node, which is electrically silent. So P wave atrial depolarization followed by that isoelectric line is called the PR interval. Now, God has made it like this because you need time for the atria to contract before the ventricle starts contracting. Now, what does it mean? It means, see, if you look at something called as a cardiac cycle, let's say it's about 0.8 seconds. How did you get that word 0.8? Did it fall from the sky? No. At a heart rate of 70 per minute, if you divide it by 60, it comes as 0.8. So for a heart rate of 72 per minute, each cardiac cycle is, that is one atrial systole and one ventricular systole is 0.8 seconds. That's how you got that 0.8. It didn't fall from the sky. What if the heart rate is 60 per minute? What will be the cardiac cycle? It's not 0.8, it will be 160 by 60. You got my point? So 0.8 second is the duration of the cardiac cycle when your heart rate is 72 beats per minute. For a heart rate of 60 beats per minute, it's 1 second cardiac cycle. Forget it. Okay. Now you understood how I got this number 0.8. Now this 0.8, atrial systole is 0.1 second, atrial diastole is 0.7 seconds. Ventricular systole is 0.3 seconds, ventricular diastole is 0.5 seconds. So look at this, there is a lazy fellow. Atria contracts only 0.1 and sleeps for 0.7. Ventricle contracts for 0.3 and diastole sleeps for only 0.5. But atria lazy fellow contracts 0.1 and sleeps off. But look at God's creation. Where is the atrial systole time? The atrial systole overlaps the last part of ventricular diastole. You know, the ventricle is fully filled. Then the atria contracts, the last part. And it empties all its blood into an already filled left ventricle or a right ventricle. And it stretches that ventricle further. And you know that the force of contraction of a muscle fiber is directly proportional to the initial length of the muscle fiber within physiological limits. That is Starling's law. So, when the atrial contraction is in the last part of ventricular diastole and the atria has completely emptied its blood into the ventricle is overstretched so that in the next contraction, it contracts powerfully according to the Starling's law. That's why, though the atria is a lazy fellow, he works for that 0.1 second. It's enough to contribute to, my friends, 30 to 40% of your cardiac output. That is the importance of atrial contribution to ventricular filling. Atria acts like a booster pump mechanism. Got my point? So, the PR interval includes this atrial depolarization, and that little time is given to flow to the atrioventricular node so that ventricle is filled with the atrial blood. That is the importance of this PR interval. Normal PR interval is, remember, 0.12 to 0.2. That is 3 to 5 small squares. If you get a short PR interval, there's something called as Wolff-Parkinson-White syndrome. Long PR interval, it's a first degree AV block. What is this Wolff-Parkinson-White syndrome? WPW syndrome means, normally from the SA node, the impulse should come to the AV node via interatrial tracts. Sometimes it so happens that this AV node is bypassed by some tracts called atrioventricular tracts. And instead of the current going through the AV node and depolarizing the ventricle, it will go through these accessory pathways and depolarize the ventricle. When you have these accessory pathways, paraseptal, anterior septal, posterior septal, all these kinds of pathways, you call it as WPW syndrome. You identify this with 3D mapping on an electrophysiological study and ablate them to prevent supraventricular tachycardia. Anyway, that's for a different day. Now, long PR interval is first degree AV block. Right. So this is how the first degree AV block looks. Long PR interval. This is the short PR interval. See how the distance between P and QR is very short. Yeah? So this is again a repetition. Normally, QRS duration should not be get something called as bundle branch blocks. Now, this is how normally it should be. Now look at this. What has happened? In lead V1 and V6, these are two leads you identify to understand what is lead, bundle branch block. See this? this is prolonged. If you look at duration from here to here, it is prolonged. And from here to here, it is prolonged. So if it is predominantly like this, R, S, R dash, in V1, positive, negative in V1. If it is positive, it is right bundle. Is negative, is left bundle. Opposite to V6. Right? See that? M shape will be in V1, right bundle. M shape in V6 will be left bundle. Right? I know you should go back and read. You just listen to my lecture, enough. Go back, you see right bundle branch block. You see left bundle branch block, then you will get to know what it is. So this is right bundle branch block. This is left bundle branch block. Why? You can see V1 negative and V6 will be positive. See that? Negative here, positive here, wide QRS in V6. This is QT interval. So QT interval is from the beginning of the Q to the ending of the T. It represents depolarization of the ventricle and repolarization of the ventricle. So this discipline is called QT interval. QT interval is depending upon the heart rate. So normally we give some correction for the heart rate, and that is called by a formula called Bezet's formula. Now Bezet's formula is this. Corrected QT is QT interval divided by square of RR interval. Like I told you, it should be 440 for males, less than, 460 for females, less than. So there's one more formula. Don't worry too much about this. So prolonged QTC, these are the conditions where you get prolonged QTC. Sleep, hypocalcemia, myocarditis, myocardial injury, drugs, hypothermia, hypertrophic obstructive cardiomyopathy. Prolonged QTC, you can get it in AV block, high degree AV block, Jervell-Lange-Nielsen syndrome, Romanov-Ward syndrome. These are called congenital QTC interval syndromes. Sometimes you can get a shortened QT, digitalis, hypercalcemia, hyperthermia, and vagal stimulation. Now comes the QRS axis. I think there are two ways of trying to find out the QRS axis. Remember, the heart is here. So the normal electrical axis is directed downward and inferiorly and posteriorly, right? So this is how normal axis is. And when you plot a normal axis, it is from minus 30 to plus 90. If it is from plus 90 to plus 180, it is called right axis. If it is from minus 30 to minus 90, is called left anterior, left axis deviation. And if it is not anywhere beyond this, it is called intermediate axis or undetermined axis. So this is how the QRS axis is determined. I know this is not going to be easy. You have to sit down, spend your time. I think I'm given very less time to explain on this. Started late, but given less time. But anyway, let me see what I can do. I'll tell you an easy method. One is to take a graph paper and plot it. And if you plot, what you need to do by plotting is take a graph paper, take lead one, see how many positive squares are there for the R wave, positive, negative, and finally, like an engineering student, you have to plot it and QRS axis. Other easy way is the quadrant approach or the equiphasic approach. You know, if it is QRS is positive, negative, some leads it's called equiphasic. Equiphasic means half positive, half negative. That's how it's going to be. Right. If the lead one is positive, lead AVF is positive, normal. Lead one negative, lead AVF positive, right axis. Lead AVF negative, lead one positive, left axis. Lead AVF negative, lead one negative, it is indeterminate axis. Can't have plotting of the axis on. So here you can see negative in lead one, positive in AVF. Where is AVF? This one. So It is right axis. This is positive in one, negative in AVF. So it's got to be left axis. Sorry, I'm not able to spend too much of time explaining. This is how it is. I think all of you should go back, open your books and read what's a quadrant approach. Equiphasic approach is something very easy. You know what we do in equiphasic approach is we take the most equiphasic lead. Now see lead 1 positive, this is negative. We don't want these two leads. See this is half positive, half negative. Which lead is this? Lead 2, RA to left leg. So if you take lead 2, take a perpendicular to that. Now if AVF is this and lead 2 is this will be the perpendicular, isn't it? So it will be minus 30. So a perpendicular to the most equiphasic lead will be the axis. Another example, here again you can see equiphasic in lead 1, positive, negative, almost equal. So if this is equiphasic, it's got to be 90 degrees. So axis is plus 9. So this is the equiphasic approach. So P wave, atrial depolarization, QRS, ventricular depolarization, P wave is ventricular repolarization. I told you about the P wave. It's seen most of the times well in lead 1, lead 2, P1. It should be not more than 2.5 millimeters in amplitude, not more than 3 boxes in terms of its duration. So if you have an atrial abnormality, you get a right atrial enlargement with tall T waves, and it's called P pulmonale. This is what it is. Can you see this? This is tall P waves. This is not supposed to be so tall. This is called P pulmonale. This is P mitral. This you see in mitral stenosis. You can see a negative deflection which is occupying more than 1 box. This is called P mitral. This is considered to be left atrial enlargement. So this is how you diagnose left atrial enlargement. This is how a normal QRS axis looks like in lead V1 and lead V6. And when you look at the QRS, you have to identify a small positive deflection in lead V1. That's called the septal R wave. Normally there's interventricular septum and it conducts from left to right. Right? So you can always see positive deflection in the right lead, the V1. And you have a septal Q wave, opposite of that, that's happening in V6. So this is about the various QRS complexes. And you look at something called as the R wave progression. Normally, there is something called as a transition zone. It grows, the R waves, it grows to a point where this becomes equal. Normally, the transition zone is either in V3 or V4. So, if the transition zone shifts, indicates either it's left ventricular hypertrophy or right ventricular hypertrophy. Now, left ventricular hypertrophy means predominant left ventricle. So, you get tall R waves in V5, V6. And when you add the R wave amplitude in V5 and the S wave amplitude in V1, and you add them together, if it is more than 35, it tells you that it is left ventricular hypertrophy. This is called Sokolov's criteria. There are so many criteria for diagnosing chamber hypertrophy, of which one of them is Sokolov's criteria. If the height of the R wave in AVL is more than 11 millimeters in men, 8 millimeters in women, it's another criteria to call that there is left ventricular hypertrophy. So right ventricular hypertrophy is again QR in V1, right bundle branch block, T wave inversion in the anterior leads, so many criteria. Once you start looking at ECGs of congenital heart diseases or ECGs of pulmonary embolism, you will get to know what is right hypertrophy. So these are all ST segment elevations which happen. So this is what? This is something all of you should know. ST elevation. On next. Look at that. This is ST elevation. 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 This is ST elev This is supposed to be the isoelectric line. So there it is. Come right up to here. So that is ST elevation. So these are all the T waves. Sometimes T waves are looking like this. U waves, sometimes you see small U waves that come after the T waves. They may be physiological. Now, I'll just take you through some disease conditions. This is the normal anatomy, right coronary artery and left coronary artery. When you get a heart attack, if you look at the ECG, it can reflect the type of heart attack, either an anterior wall MI, posterior wall MI, true posterior wall MI, inferolateral MI, lateral MI. So depending upon certain characteristics, you can identify where the MI is. So this is how the ST segment is. It is normal. Here it is elevated. Here it is depressed. Now, how do you know it is elevated? How do you know this is depressed? It is with respect to isoelectric line. If you draw a line from here to here, it is considered to be isoelectric. Here it is depressed. Right. So this is something called as the J point. This junction between the ST segment and the S wave is called the J point. If this goes up, it's called ST segment elevation. So it can be cone or it can be convex upwards. So this is how it looks like. See here, this is supposed to be the isoelectric point, ST segment elevation. This is supposed to be the isoelectric point, ST segment depression with T invasion. So if you get ST elevation in V1 and V2, it's a septal MI. V3, V4, it's an anterior MI. 1 AVL, V5, V6, it's a lateral MI. And if it is 2, 3 and AVF, it's an inferior wall MI. So this is how you anatomically group the MIs. 1 AVL, V5, V6, lateral. V3, V4, anterior. V1, V2, septal. 2, 3 AVF, inferior wall MI. So you should look for these ST segment elevations in these corresponding leads to categorize a patient as having inferior wall MI, anterior wall MI, anteroseptal MI, lateral MI. What MI is this? V1, V2, V3, V4, V5, V6. It's an extensive anterior wall MI. It's involving even 1 and AVL. So it's an extensive anterior wall MI. Anterior, septal, lateral, everything is involved. Look at that. This is what? 1, AVL, V5, V6, ST elevation. So this is lateral MI, anterolateral MI. V1, lead 1 is okay, depression. Lead 2, ST elevation. Lead 3, ST elevation. AVF, ST elevation. So what MI is this? Inferior wall MI. So there are a lot of drugs also which cause the problems. Hyperkalemia, this is what it does. You can see widening of the QRS. You can see tall tented P waves in this. And this is finally what happens. Patient goes into bradycardia and he gets sinusoidal P waves. Then he may go into complete heart block. So hypocalcemia, hypercalcemia, digitalis, they are all that they affect the ECG. So when you look at bradyarrhythmias, you have sinus bradycardia, junctional rhythm, sinoatrial block, atrioventricular block. Now this is sinus bradycardia. All complexes are okay, but if you look at the heart rate, 1, 2, 3, 4, 5, 6. So which means a heart rate of 50 per minute. That is less than 60 per minute, but regular. Every P wave before QRS, ER interval is normal, so it's a sinus bradycardia. Here, you see that the heart rate is between 40 to 60. It's a junctional rhythm, and the P waves is absent here. Sometimes they may follow the QRS complex also. Sinoatrial block, suddenly there's no P wave coming here at all. This is 6 sinus syndrome. Yeah, no P wave at all. AV block can be first degree, second degree, third degree. In first degree AV block, you just get only prolongation of the PR interval. That's all. Everything else is there, normal. So if there is prolongation of the PR interval, it is called first degree AV block. Normal PR interval is 0.12 to 0.2. Anything more than 0.2 is abnormal. It's called first degree AV block. Second degree AV block, this is how it looks. See here what is happening in second degree AV block. This is the PR interval, becomes prolonged, P comes no QRS. So PR goes on becoming prolonged. As the PR goes on getting prolonged, it's followed by a drop in the QRS. That is called as Wenckebach phenomena, or it's called Mobitz type 1 block. In Mobitz type 2 block, there is one P wave which doesn't get conducted at all, but the PR interval doesn't vary. There is no successive prolongation of the PR interval. The PR is varied with a varying, with a fixed PR. The QRS doesn't come. One P wave doesn't get conducted. That is called as Mobitz type 2 block. This is called 2:1 block, Mobitz type 2 block. And third degree block, there is no relationship at all between the P wave and look at this P here, look at this P. There is no relationship at all, isn't it? The P waves fall where they want. The QRS waves, they come when they want. But there is a relationship, fixed relationship between RR, a fixed relationship between PP. But the PR do not relate to each other. This is called AV dissociation or complete heart block. So arrhythmia formation, sinus, atrial, AV junction. These are all things, these are all for quiz, I think. So how you should be looking at, if there are good P waves, the PR interval is normal, QRS duration is normal, everything is normal, it's sinus bradycardia. Here, the rate is more. P wave is normal, PR interval is normal, QRS duration is normal, everything is normal, but the rate is more. So it is sinus tachycardia. Now, if somebody asks you what is a normal heart rate, you should always say it is 61 to 99. 60 and below is bradycardia. 100 and above is tachycardia. Please remember this. Heart rate is never one fixed number. 61 to 99 is the normal heart rate. The moment it touches 100 and above is tachycardia. The moment it touches 60 and below is bradycardia. You should have a clear but mathematical conception about the heart rate. So these are premature atrial contraction, nothing much about it. See this P wave, see this P wave, they're different. So the QRS is narrow, it's not wide. So it's a premature atrial contraction. If this beat should have come, next beat should have come here. It has come early. So see the distance between these two beats, but this has come early. So it is premature and abnormal P wave, narrow QRS. So it's premature atrial contraction. So supraventricular arrhythmias can be atrial fibrillation, atrial flutter, supraventricular tachycardia. So this is the typical sawtooth appearance. So this is atrial flutter, right? This is paroxysmal supraventricular tachycardia. See, this was all normal. See, suddenly what happened? Can you see the change? This is normal. From here on, see the rate. It is supraventricular tachycardia, runs of supraventricular ectopics, but they are all narrow QRS. Right? This is very abnormal looking beat, and this is a ventricular premature contraction or premature ventricular contraction. I'm sure all of us are very good at picking this up. So this is ventricular tachycardia. There's so many ways of diagnosing ventricular tachycardia. Ventricular tachycardia kills if you don't take action, isn't it? VT needs to be cardioverted electrically if it is hemodynamically significant, or pharmacologically if you have the time. So this is one lead. This is called Wernicke algorithm. By looking at one lead, AVR, if you have a dominant R, it's a VT. If you have an initial Q, which is more than 40 milliseconds, it's a VT. If there's a notch downstroke of the QRS, it's a VT. And if you have voltage delta in the last 40 milliseconds, it is VT. So one lead can identify VT. This is ventricular fibrillation. This is most of the times the terminal rhythm. Ventricular fibrillation, no questions asked. Forced ventricular fibrillation has to be what? Electrically cardioverted, isn't it? So the last 10 slides, Professor Chamberlain's 10 rules. Rule 1, PR interval should be 120 to 200 or 3 to 5 lit squares. Rule 2, width of QRS complex should not exceed 110. Rule 3, QRS complex should be dominantly upright in lead 1 and AVF. Rule 4, QRS and T waves tend to have the same general direction in the limb links. Rule 5, all waves are negative in lead AVR. All waves are negative in lead AVR. If AVR is positive, it means what? Right ventricular hypertrophy. Rule 6, R wave must grow from V1 to V4. S wave must grow from V1 to at least V3 and disappear in V6. S wave should not be seen in V6. If at all you see, it will be small, maybe 1 millimeter or 2 millimeter, not more than that. Rule 7, ST segment should always be isoelectric. Rule 8, P wave should be upright in 1, 2 and V2 to V6. There should be no Q waves or only small Q of less than 0.04 seconds or less than 25% of R wave in 1 to V2 to V6. Otherwise, these waves will not be called physiological. They will be called pathological Q waves. Pathological Q waves means MI, old MI, necrotic tissue already has formed. T wave must be upright in 1 to V2 to V6. Thank you. Thank you for your patience. And I know it's been a lengthy presentation, but given the short time, this is the best that I could do. Thank you for your patient listening. Any questions, anything, any point of time, I'm always. Thank you.
Hello. Thank you so much, sir. We request all the dignitaries to please stay in the platform because in our upcoming session, sir will be providing few goodies for all the attendees. Next, we have Foot Care for Everyone and Everywhere by Dr. Sunil Curry from Mandakini Hospital, Hubballi. Please give a huge round of applause as we welcome sir on the stage. Sunil Vasudev Curry, Senior Consultant Diabetic Foot Surgeon, Head and Department of Diabetic Limb Salvage, Chief of Diabetic Foot Salvage Team, and he's been a member of Indian Medical Association and also the Association of Surgeons of India. He's also an academic member of RSSDI Delhi, KRSSDI Karnataka, Asia Pacific Diabetic Limb Problem Association Singapore. He has given various lectures and we are a huge honor for us to have sir in our occasion today.
Well, good morning. Indeed a pleasure to share something unique where I could see a small, really interested group in foot care sitting right in front of me. And I think the rest of the show, they should understand it. So I think I have to take it in Kannada also because they as a paramedic staff sitting in the last few rows, ಅವ್ರಿಗೂ ಗುರ್ತಾಗಲೇಬೇಕು. ನೀವೇನು ಲಾಸ್ಟ್ ರೋನಾಗ ಕೂತಿರಲ್ಲಮ್ಮ, ನೀವೆಲ್ಲರೂ ಕಾಲು ನೋಡ್ತಿರ್ತೀರಿ, ಡ್ರೆಸ್ಸಿಂಗ್ ಮಾಡ್ತಿರ್ತೀರಿ, ನಿಮಗೂ ಗುರ್ತಾಗಲೇಬೇಕು. ಅದನ್ನೇ ನಾ ಹೇಳಿಕ್ಕೆ ಇಲ್ಲಿ ಬಂದಿದ್ದೇನೆ. ಎದುರುಗಡೆ ಕೂತಂತಹ ಟಾಪ್ ಪ್ರಯಾರಿಟಿ ಏನು ಡಾಕ್ಟರ್ ಸೀನಿಯರ್ ಮೋಸ್ಟ್ ಕೂತಿದ್ದಾರೆ, ಅವ್ರಿಗೆ ಬಹಳಷ್ಟು ಹೇಳುವಂಥದ್ದು ಏನಿಲ್ಲ ನಾನು, ಆದರೆ ಕ್ಲಿನಿಕಲ್ ಟಿಪ್ಸ್, how a foot behaves in diabetes, what exactly I should do on Monday when I start my practice in my clinic. That is important. I'm not going to show you any kind of literature, any research, nothing. I'm going to give you a clinical tips right in front of you. There are 3 tables. I'm going to show you what is importance of a footwear science, what is importance of exercise science, how I can heal a ulcer in the foot in my clinic. That is my priority. That is what I have been doing past 25 plus years in Hubli. I don't see anything above groin. I have been seeing only limbs and lower limbs. I have brought this figure. You're all very fascinated to know. You're all fascinated to know the color. The red is artery, the blue is vein. No, I'm more interested. You check your footprints. I want all those doctors sitting in front of me should see that those 2 footprints should be maintained throughout of all the diabetics. ಪ್ರತಿ ಡಯಾಬಿಟಿಕ್ ವ್ಯಕ್ತಿಯ ಆ 2 ಬಲಗಾಲು ಎಡಗಾಲು ಪ್ರಿಂಟ್ ಯಾವಾಗಲೂ ಕಾಣಲೇಬೇಕು. That is what is care. If losing little toe, great toe, that means we have not done a proper job in our workup. I will ask you a simple request. I'm going to. How many doctors are here in this hall? Please stand up. How many doctors are there? Please stand up. I request you to 1 second stand up. Look at it, how important limb is. How important it is holding your weight. It is so difficult in diabetes to operate on this limb and hold this weight. No organ in the body takes the body weight. Heart doesn't take body weight. Brain doesn't take body weight. Please sit down. My staff will give you a special kit. I think, where is my staff? Just doctors get a kit. I'm going to demonstrate you why that kit is important, how I have designed it, how I have learnt in last 25 years, how I should reach to my colleagues. Very, very important. Every item in that kit is so important. It is having a binding with a doctor and a binding with the patient. I want you to understand that. What is there in that kit? Only doctors should have that kit. ಬಾಕಿದವ್ರು ಯಾರು ತಗೋಬಾರ್ದು, ಪ್ಯಾರಾಮೆಡಿಕಲ್ ಸ್ಟಾಫ್ ಹಚ್ಚಬಾರ್ದು ಕೈ. ಅದಕ್ಕೆ there is a very straightforward 2 photographs are there on that bag. In the kit ಮೇಲೆ ನೋಡಿ, ಫ್ರಂಟ್ ಮತ್ತು ಬ್ಯಾಗ್ ನಲ್ಲಿ ಸೇವ್ ದ ಲಿಂಬ್ ಟು ಪ್ರೊಲಾಂಗ್ ದ ಕ್ವಾಲಿಟಿ ಆಫ್ ಲೈಫ್. ಪ್ರತಿ ಡಯಾಬಿಟಿಕ್ ವ್ಯಕ್ತಿಯಲ್ಲಿ ನೀವು ಕ್ವಾಲಿಟಿ ಲೈಫ್ ಕೊಡ್ಲಿಕ್ಕೆ ಪ್ರಯತ್ನ ಮಾಡಿ. There are so many things written here. Ulcer, infection, gangrene, varicose ulcer, there is a block. So many things are there. This is what a unit. We have a comprehensive foot care. What is comprehensive foot care? I will show you. My son has joined me, Shank, who is a endovascular and open. He is a vascular surgeon, where he has made a big difference in last 1.5 years, where we are working on every segment of vascular work. This is what I am here with you to empower the healthcare worker in rural segment. I am not looking at metro segment. I am looking at rural segment, where I don't want any doctor to refer me any patient. This is how preventing the first ulcer in diabetes is very important. I don't want any artificial Jaipur foot also to my rural patient. Jaipur foot ge 2,500 ರೂಪಾಯಿ ಸರ್, ಬೇಡ ನಮಗೆ. ನಮ್ಮ ಹಳ್ಳಿ ಜನಗೆ ಅದು ಜೈಪುರ್ ಫುಟ್ ಕೂಡ ಬೇಡ. ಹಾಗೆ ನಾನು ಆ ಕಾಲನ್ನು ಪ್ರಿವೆಂಟ್ ಮಾಡ್ತೀನಿ. I want an Indian rural diabetic foot forward to avoid Jaipur limb. That should be the motto of every person who is sitting in this hall. ಎಲ್ಲರಿಗೂ ಬರ್ತದೆ ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್. ಈಗ ಜಸ್ಟ್ ಮಾತಾಡಿದ್ರು ಸರ್, he showed you n number of ECGs. Thak, thak, thak. ಆಂಬ್ಯುಲೆನ್ಸ್ ನಿಮ್ಮ ಊರಲ್ಲಿ ಓಡಿತು ಗಂಗಾವತಿನೆಲ್ಲ ಅಂದ್ರೆ ಎಲ್ಲರೂ ಹೇಳ್ತಾರೆ ಏನೋ ಆಕ್ಸಿಡೆಂಟ್ ಆಯ್ತು, ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್. ಯಾರಿಗೂ ಫುಟ್ ಅಟ್ಯಾಕ್ ಅಂದ್ರೆ ಗೊತ್ತಿಲ್ಲ. ದೇರ್ ಇಸ್ ಅ ಬಿಗ್ ಇಶ್ಯೂ ಆನ್ ಫುಟ್ ಅಟ್ಯಾಕ್. ಯಾವುದು ಮೊಳೆ, ಎನಿ ಪೆನಿಟ್ರೇಟಿಂಗ್ ಇಂಜುರಿ. ಇಫ್ ಪೇಷಂಟ್ ಸರ್ ನನ್ನ ಮೊಳೆ ಚುಚ್ಚುತ್ರಿ, ದಟ್ ಈಸ್ ಫುಟ್ ಅಟ್ಯಾಕ್. The infection has reached from the plantar skin to directly to the metatarsal compartment. You can't waste time there. It has to be emergency treatment. Please understand foot attack. How we can reach? You can reach through so many ways now. Immediately it needs care. What is the outcome of early work and early reference? Look at it. Day 1, day 100. Every wound heals in 100 days. Every week there is 10% reduction in the size. What are the pillars? Metabolic correction, vascular correction, microbiology, wound education. And the most important is late reference can end up in such kind of workup. Patient ಹೇಳ್ತಾರೆ ಸರ್ ನೀವು ಕಾಲ ಮೇಲೆ ನಡಿಬೇಡ ಅಂತ ಹೇಳಿಕತ್ತೀರಿ. ಹೇಳ್ತೀರಿ ನಾವು ಹೆಂಗೆ ನಡಿಬೇಕು? ಹಂಗಿದ್ರೆ ಕೈ ಮೇಲೆ ನಡಿಬೇಕಾಗ್ತದೆ ಪೇಷಂಟ್ ಅನ್ನ. ಸೊ ಇಫ್ ವಿ ಡೋಂಟ್ ಆಫ್ಲೋಡ್ ದಿ ಫುಟ್, the well which is having wound, you have reduced the body weight, then only the patient can walk on his foot, and that is a science. ಇದು ನಿಮ್ಮ ಬ್ಯಾಗ್ನಾಗದ ನೋಡ್ರಿ, ಯು ಕ್ಯಾನ್ ಓಪನ್ ಅಂಡ್ ಸಿ ದಟ್ ಬ್ಯಾಗ್. ಒಂದು ಚಾರ್ಟ್ ಕೊಟ್ಟೆ ನಾನು ನಿಮಗೆ, ಎಲ್ಲರೂ ಸಣ್ಣಾಗಿರ್ತಾಗ ಆಟಾಡ್ತಾರೆ. ಈ ಚಾರ್ಟನ್ನು ಹೊರಗೆ ನಿಮ್ಮ ಒ ಪಿ ಡಿ ವೇಟಿಂಗ್ ರೂಮ್ನಾಗ ಇಡ್ಬೇಕು, ಪೇಷಂಟ್ಗೆ ಹೇಳ್ಬೇಕು. ಸ್ನೇಕ್ ಆ್ಯಂಡ್ ಲ್ಯಾಡರ್, ನಮ್ಗೆ ಲ್ಯಾಡರ್ ಬೇಡ, ಸ್ನೇಕ್ ನೋಡ್ರಿ. ಏನೇನು ಸ್ನೇಕ್ಸ್ ಅದಾವ? ಮೆಟಬಾಲಿಕ್, ನೀ ಸಕ್ಕರೆ ಕಂಟ್ರೋಲ್ ಮಾಡಲಿಲ್ಲ ನಿನ್ನ ಕಾಲಿಗೆ ತೊಂದರೆ ಆಗ್ತದ. ನಂಬರ್ 1 ಸ್ನೇಕ್ ಅಲ್ಲೇ ಕೂತಾನ. ಎರಡನೇದು ಎಜುಕೇಶನ್, ಸರಿಯಾಗಿ ಕಾಲಿನ ಕಾಳಜಿ ಮಾಡು. ಇದು ಎಜುಕೇಶನ್ ಮಾಡಲಿಲ್ಲ, 2ನೇ ಲೆವೆಲ್ಗೆ ಸ್ನೇಕ್ ಕೂತಾನ, ಮತ್ತೆ ನೀವು 0ಗೆ ಬಂದು ಕುಂದಿರ್ತೀರಿ. 3rd ಲೆವೆಲ್ ಆಫ್ಲೋಡಿಂಗ್, ಗಾಯ ಆಗಿದೆ ದೆನ್ ಆಫ್ಲೋಡ್, ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ಇನ್ನೊಂದು ಸ್ನೇಕ್, ಪ್ರಾಪರ್ ವುಂಡ್ ಕೇರ್ ಎಲ್ಲ ಮಾಡ್ಲಿಕ್ಕತ್ತೀರಿ, ರಕ್ತ ಬರಾಕತ್ತಿಲ್ಲ ಕಾಲಾಗ, ವ್ಯಾಸ್ಕ್ಯುಲರ್ ಕೇರ್. ದೆನ್ ದೆರ್ ಇಸ್ ಅ ಬಿಗ್ ಸ್ನೇಕ್ ಸಿಟಿಂಗ್ ದೇರ್, ಯು ಕ್ಯಾಂಟ್ ರೀಚ್ ಟು ದ 100. And education, microbiology, pus culture ಮಾಡೋದೆಲ್ಲ ಈಗ ಹೋಯ್ತು. You have to have a tissue and bone culture, which are very specific. You can't shoot antibiotics randomly. Very, very important. Now you have got one more thing. ಇದು ಒಂದು ಕಾರ್ಡ್ ಕೊಟ್ಟಿದ್ದು ನೋಡ್ರಿ, ನೀವೆಲ್ಲ ಪೇಷಂಟ್ ನೋಡ್ತಿರ್ತಾರ, ಅವ್ರು ಬೇರೆ ಬೇರೆ ಗಾಯಗಳು ಕಾಲಲ್ಲಿ ಆಗಿದಾವ. ಹಿಂಗೆ ಗಾಯ ಆತು, ಇಫ್ ಸಂಬಡಿ ಕಮ್ಸ್ ಟು ಯು, ನಾ ಏನು ಮಾಡ್ಬೇಕು? ಕ್ಲಿನಿಕ್ನಲ್ಲಿ ಮಂಡೇ ನಾನು ಏನು ಮಾಡಬೇಕು? ಫಸ್ಟ್ ಸ್ಟ್ರೆಟಿಫೈ ಮಾಡಿ, ಇಸ್ ಇಟ್ ಎ ಲೋ ರಿಸ್ಕ್, ಇಸ್ ಇಟ್ ಎ ಮೀಡಿಯಂ ರಿಸ್ಕ್, ಇಸ್ ಇಟ್ ಎ ಹೈ ರಿಸ್ಕ್? ಪ್ಲೀಸ್ ವರ್ಕ್ ಆನ್ ದಿಸ್ ಕ್ರೈಟೀರಿಯಾ. ಸರ್ ನನ್ನ ಕಂಟ್ರೋಲ್ ಐತ್ರಿ, ಕಾಲಿಗೆ ಏನು ತೊಂದರೆ ಇಲ್ಲ, still you have to work 0. He has to attend you every year. Every year he has to come for a foot checkup. Please stratify every patient for the foot, in what stage he is. It was very interesting. Diabetic foot protection mantra ಅಂದ್ರೆ ಅಷ್ಟ ಪೇಷಂಟ್ ಓದ್ತಾವ, ಇಲ್ಲ ಓದಂಗೆ ಹೇಳೋ ಮಂತ್ರ ಇದ್ರೆ ನಾವು ಓದ್ತೇನೆ ಸರ್ ಅಂತ ಹೇಳ್ತಾರೆ. I have given you 2 mantras. ಅದನ್ನ ನೀವು ನಿಮ್ಮ ಒ ಪಿ ಡಿ ವೇಟಿಂಗ್ ಹಾಲ್ನಾಗ ಇಟ್ಬಿಡ್ರಿ. ಅದನ್ನ ಅವ್ರು ಎಲ್ಲರೂ ಓದ್ಕೊಂಡು ಬರ್ಬೇಕು. ಒಳಗೆ ಬರ್ಬೇಕಾದ್ರೆ ಅವ್ರು ಕ್ವಶನ್ ಕೇಳ್ಬೇಕು ನೀವು, ಸರ್ ಇದೇನ್ರಿ ಇದು ಏನೋ ಬರ್ದಿರಲ್ಲ, ನೀವು ಏನದ ನಾವು ಏನು ಹೇಳ್ಬೇಕು? ಕಾಲಿಗೆ ನೋಡ್ತೀರಿ, ನನ್ನ ಕಾಲಾಗಿನ ಚಪ್ಪಲಿ ಜಾರ್ಲಿಕ್ಕೆ ಹತ್ತದ ಗುರ್ತಾಗೋಲ್ತು. That itself is a neuropathy. If it tells you something, that itself is a neuropathy. Try to understand this science. ಒಂದು ನೇಲ್ ಫೈಲರ್ ಕೊಟ್ಟೆ ನಾನು ನಿಮಗೆ. I have given you one nail filer, you can see. Please make it a point. ನೇಲ್ ಥಿಕ್ ಆಗಿರ್ತಾವ ಡಯಾಬಿಟಿಸ್ನಾಗ, ಕಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಹೋಗಬೇಡಿ, ಫೈಲ್ ಮಾಡಿ ಸರಿಯಾಗಿ, ಜಸ್ಟ್ ಫೈಲ್ ಇಟ್. ಪೇಷಂಟ್ಗೂ ಎಜುಕೇಟ್ ಮಾಡಿ, ನೇಲ್ ಕಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಹೋಗಬೇಡ, ಅಲ್ಲಿ ಗಾಯ ಮಾಡಿದೆ ಅಂದ್ರೆ ಅದೇ ಮುಂದೆ ದೊಡ್ಡ ಗ್ಯಾಂಗ್ರೀನ್ ಆಗಿ ಕುಂದಿರ್ತದೆ. So always make it a point. Doctor himself should have a nail filer to show to him. ಇದು ಹೋಗಿ ಮಾರ್ಕೆಟ್ನಾಗಿಂತ ತಗೊಳ್ಳುವ. The doctors who are sitting in this hall should know what is my CPR score to save the limb. I have to check, which is a priority. Every foot has to be checked. ಅದಕ್ಕೆ ನಾ ಕೊಡೋದು ಕೇವಲ 2 ಮಾರ್ಕ್ಸ್. ಐ ಆಮ್ ಗೋಯಿಂಗ್ ಟು ಪ್ರೊಟೆಕ್ಟ್, ನಾ ಅದನ್ನು ಕಾಳಜಿ ಮಾಡ್ತೀನಿ, ಅದಕ್ಕೆ 3 ಮಾರ್ಕ್ಸ್ ಕೊಡ್ತೀನಿ. ಐ ಡೋಂಟ್ ನೋ, ನನಗೇನು ಇದ್ರ ಬದಲು ಹೆಚ್ಚಿಗೆ ಮಾಹಿತಿ ಇಲ್ಲ. ಪ್ಲೀಸ್ ರೆಫರ್. ಇಫ್ ಯು ಡೋಂಟ್ ನೋ ಎನಿಥಿಂಗ್, ಡೋಂಟ್ ಕೀಪ್ ಇಟ್ ವಿತ್ ಯು, ರೆಫರ್ ಇಟ್ ಟು ದ ಹೈಯರ್ ಸೆಂಟರ್. ಅದಕ್ಕೆ 5 ಮಾರ್ಕ್ಸ್ ಕೊಡ್ತೀರಿ. ಸೊ ಯು ವಾಂಟ್ ಟು ವಿನ್ ದಿಸ್ ಗೇಮ್, you should have 10 out of 10 in a right way in your day-to-day practice. You can't just see that, na ಮಾಡ್ತೀನಿ ನಾನು ಆರಾಮ್ ಮಾಡ್ತೀನಿ. No, the delay in reference has led to maximum morbidity, maximum mortality. Look at it. In few seconds, we were planning to host whatever these figure you are seeing there. I had promised Malalguda sir that I want to see that 54 feet height crutch I want to design in this next hall. He had given a space, and we had requested all the authorities in the world record. They were unable to reach us, so we couldn't do that. But definitely we'll do it in some time. And this is how they are losing the limb in diabetes. Highest. They are losing maximum. Every 20-second one is lost due to diabetes somewhere in some part of the world. ಈಗ ನನಗೆ ಅವರು 2 ತಾಸು ಮಾತಾಡಕ್ಕೆ ಕೊಟ್ಟಾರೆ. 60 ನಿಮಿಷನಾಗ ನೀವು ಏನಿಲ್ಲ ಅಂದ್ರೂ 180 ಕಾಲು ಹೋಗ್ಯಾವ ದಳಲ್ಲ ಅಂತ. ಅಂದ್ರೆ 360 ಹೋಗ್ಯಾವ ಈಗ ಆಲ್ರೆಡಿ ನಮ್ಮ ಮುಗಿಸೋತಕ. So look at it, how the speed. Somebody has to stop this watch. We have to work on this area. We need to be more clinical. The inertia has to go. The physicians are having a lot of inertia. Surgeons, I don't have any job if you prevent the first ulcer in the foot. I don't have any job. I can change, I can go to different work. This is what is very important. We need to prevent amputations. Now, there is one calendar I have given you, 2026. Please open and see that calendar. And that calendar will boost your inspiration, how I can save the limb in diabetes. The first page of the calendar says, from sore to soothe, our foot care is unmatched. The calendar will definitely tell you the first story, January, before after. The 4-foot ulcer has healed, andre na ಗಾಯನ್ನು ಮಾಯಿಸಬಹುದು ಆಯ್ತು. ಹಿಂಬಡಿದ ಗಾಯನು ಕೂಡ ಮಾಯಿಸಬಹುದು. ಆನೆ ಕಾಲು ಕೂಡ ಸರಿ ಮಾಡಬಹುದು. Elephantiasis can also be treated well. Blocks can also be taken care. ಹೇಗೆ? How it should be done? With a guideline, with international working group guidelines ಅದಾವ ಅದಕ್ಕೆ. I have given you comprehensive foot care. Simple steps. You have to have neuropathy assessment, vascular assessment, footwear assessment, pressure assessment, and wound care assessment. ಎಲ್ಲರೂ ಕೇಳ್ತಾರೆ ನನಗೆ ಯೂಶುವಲಿ ಮೋಸ್ಟ್ ಆಫ್ ದ ಟೈಮ್, ಸರ್ ಯಾವುದು ಚೆನ್ನಾಗಿ ಸರ್? ನನಗೆ ಟೈಮ್ ಇರೋದಿಲ್ಲ ಸರ್. 100 ಪೇಷಂಟ್ ಇರ್ತಾರೆ ಸರ್. ನಮ್ದು ಮ್ಯಾಕ್ಸಿಮಮ್ ಒಪಿಡಿ ಸರ್ 120, 130 ದಿವಸಕ್ಕೆ ಇರ್ತದೆ. ನಾ ಹೇಗೆ ಮಾಡಲಿ ಅದನ್ನು PNP ಅಸೆಸ್ಮೆಂಟ್? ಓಕೆ, ನಿಮ್ಗಿಲ್ಲಲ್ಲ, ಐ ವಿಲ್ ಶೋ ಯು ನೌ ವಾಟ್ ಶುಡ್ ಬಿ ಡನ್. One of my patient will come and lie there. What is a quick assessment when the foot is going to break? This is the thing you should follow. This is the guideline. You need not take any photograph, sir. It is there right in your calendar. It has to be on your tabletop. Daily practice. You should keep it on your table and you should see those calendars. This is how you have to follow the stepwise pattern. Next, what footwear I have to buy? ಯಾವಾಗ ತಗೋಬೇಕು ಚಪ್ಪಲಿ ನಾನು? I have brought you all the footwears here. ಸರ್ ಯಾವಾಗ ಖರೀದಿ ಮಾಡ್ಬೇಕು ನಾನು? ಆಮೇಲೆ ಇದರ ಆಯುಷ್ಯ ಎಷ್ಟು? The man who is having neuropathy in diabetes, ಆ ಚಪ್ಪಲಿಯ ಆಯುಷ್ಯ ಕೇವಲ 3 ಇಂದ 4 ತಿಂಗಳ ಮಾತ್ರ. Only 3 to 4 months, not more than that. ನಮ್ಮ ಇಂಡಿಯಾನಾಗ ಏನಂತಾರೆ, ಹರಿಯುತ್ತನ ಚಪ್ಪಲಿ ನಂದ, ಅದು ಹರಿದು ಹೋದ್ರೂ ಹಾಕೊಂಡು ಅಡ್ಡಾಡ್ತಾರ ನಮ್ಮ ಕಡೆ ಮಂದಿ. So please make these points very clear. If a diabetic is there, check his insole, outer sole and top. And insole, if it is 9 mm, it is ideal. If it reduces by 50%, sir chalo itri, ತೆಗ್ಗಾಗೈತ್ರಿ, gone. ಅವನಿಗೆ ಅಲ್ಸರ್ ಆಗಿಬಿಡ್ತದೆ. ಆ ಚಪ್ಪಲಿಯಾಗ ತೆಗ್ಗದು ಅಂದ್ರೆ ಅಲ್ಸರ್ 100%. Everyone sitting in this hall, especially IMA, GPs, which I request, general practitioners, healthcare workers, patient ಸಕ್ರಿ ಹೆಚ್ಚಿಗೆ ಆತ ಅಂದ್ಕೊಳ್ಳಿ. ಯಾಕೆ ಓಡಿಲ್ಲ, ಜಿಗಿದಿಲ್ಲ, ಎಕ್ಸರ್ಸೈಸ್ ಮಾಡಿಲ್ಲ, ಯು ಕೀಪ್ ಆನ್ ಶೌಟಿಂಗ್ ಅಟ್ ಹಿಮ್. ಬರೀ ತಿನ್ನಕತ್ತೀರಿ, ನೀವು ಸ್ವೀಟ್ ತಿನ್ನಕತ್ತೀರಿ, ಎಕ್ಸರ್ಸೈಸ್ ಮಾಡಕತ್ತಿಲ್ಲ. What evidence you have to say that he should run, jump and jog, that his foot is normal? Have you taken an X-ray? Have you gone through his workup? Is he having ulcer? Is he having shark foot? You need to assess the foot before you give any exercise advice to the patient. So we make it very clear that low risk feet, he can have a walk of 10,000 steps, medium risk 5,000 steps, high risk minimize the number of steps. High risk feet is very dangerous if you start walking. Nan sakri kadime agilri, nan nadibekri, nan sir elarri. I shout at my patients, don't walk. If you are walking, you are breaking the feet. How it breaks, I will show you. Now, sir, there are units available now. Sit in the house, keep on doing this simple exercise where there is no body weight on the feet. Nimma kaalina mele, nimma dehara irlebaardu. Exercise ಮಾಡಬಹುದು. This is very important. I have seen every doctor wants to do dressing by a staff who are sitting there. ನೀವೆಲ್ಲರೂ ಮಾಡ್ತೀರಲ್ಲಮ್ಮ ಡ್ರೆಸ್ಸಿಂಗು? ಹಿಂದೆ ಕೂತವ್ರು ಎಲ್ಲ ಪ್ಯಾರಾಮೆಡಿಕಲ್ ಸ್ಟಾಫ್ ಡ್ರೆಸ್ಸಿಂಗ್ ಮಾಡ್ಲಿಕ್ಕೆ ಹೇಳ್ತಾರೆ ನಿಮಗೆ. ಆ ಗಂಟು ಕಟ್ಟಾರ ನೋಡಮ್ಮ ಅಲ್ಲಿ, ಅವ ಹ್ಯಾಂಗ್ ಗಂಟು ಹಾಕ್ಯಾರ ನೋಡಲ್ಲಿ. Look at that. It has been placed over there. Can you see? The most dangerous way of doing dressings. Never put a knot of a dressing on the plantar area or on the dorsal area. Plantar area, it increases the pressure. On dorsal area, it cuts off the pressure, vascular flow. Simple thing. Role of dressing in DFUs. Dressing heals the wound. Patient ಬಂದು ಸರ್ ನಾನು ಸರ್ ಹೇಳ್ಯಾರ್ರಿ ಡ್ರೆಸ್ಸಿಂಗ್ ಮಾಡ್ಕೊತ ಹೋಗ ಆರಾಮಾಗ್ತೈತಿ. If that would have been case, why so many patients are getting admitted? In every medical college, 25% of the surgical beds are occupied by diabetic foot. Dressing ಮಾಡಿದ್ರೆ ಆರಾಮಾಗ್ತದ್ರ? No. Properly selected dressing enhances the body's ability to heal the wound. Please understand, dressings don't heal the wound. Sir, ಹೆಂಗೆ ಅದನ್ನು ಮ್ಯಾನೇಜ್ ಮಾಡ್ಬೇಕು ನಾವು? ಹಂಗಿದ್ರೆ HbO2 hyperbaric oxygen ಕಳಿಸ್ಬೇಕಲ್ರಿ, ವ್ಯಾಕ್ ಮಾಡ್ಬೇಕಲ್ರಿ. See, look at knowledge. They don't want to apply clinical what I am supposed to do. Normal saline is what is evidence-based practice up till now. That is the best remedy. Daily high soakage is there, you can do it twice a day. See that wound bed is prepared well. Can you see how beautiful everything has healed in 100 days? So what I am supposed to do, I will show you. I have brought the plaster. TCC hang ಹಾಕಬೇಕು. ನಿಮ್ಮ ಕ್ಲಿನಿಕ್ನಾಗ ನೀವು TCC ಹಾಕ್ಲಿಕ್ಕೆ ಬರ್ತೈತಿಲ್ಲ. ಇಲ್ಲ ಸರ್ ನಾ ಆರ್ಥೋಪೆಡಿಕ್ಸ್ ಹೇಳ್ಬಿಡ್ತೇನೆ ರೀ, ನಾ ಸರ್ಜನ್ಗೆ ಹೇಳ್ತೇನೆ ರೀ. No, a GP can do it. I will demonstrate here. It's a very simple technique. 4 foot ulcer ಇರಲಿ, mid foot ಇರಲಿ, hill foot ಇರಲಿ, simple TCC ಹಾಕ್ರಿ, ಆಪರೇಷನ್ ಬೇಡ, ಏನೂ ಬೇಡ, everything heals well. When you can do this, why the patient is going in so many complications? I will show you a simple videos. I want you to enjoy this. Then I will go with live workshop, how one has to do it. See, look at it, how the heel strikes and take off. Namma himbada modal nelak thud anta hodittada. That is almost around, say, more than 3 times of our body weight. ನಾ 60 ಇದ್ದಿಂದ 180 ಕಿಲೋ ಹೀಲ್ನಾಗ ಹೊಡಿತದ. ದೆನ್ ಟೇಕ್ ಆಫ್ ಏನಾಗ್ತದ 6 times ಆಫ್ ಅವರ್ ಬಾಡಿ ವೇಟ್. ದಟ್ಸ್ ದ ರೀಸನ್ ನಿಮ್ಮ ಕಾಲಲ್ಲಿರುವಂತಹ ಸಕ್ಕರೆ ಕಾಯಿಲೆ ಎಲ್ಲ ಪೇಷಂಟ್ಗಳಿಗೆ ಮುಂಭಾಗದಲ್ಲಿ ಗಾಯಗಳಿದಾವ, ನಡಕ್ಕ ಹಿಂಭಾಗದಲ್ಲಿ ಹೆಚ್ಚಿಗೆ ಗಾಯ ಇಲ್ಲ, ಎಲ್ಲ ಮುಂಭಾಗದಲ್ಲಿ ಇದಾವ. ಬಿಕಾಸ್ 6 times ಆಫ್ ಯುವರ್ ಬಾಡಿ ವೇಟ್ ಹಿಟ್ಸ್ ದಿ ಗ್ರೌಂಡ್. ನೆಕ್ಸ್ಟ್ ಹೆಂಗ್ ಹಿಂದಿನ ಹೆಂಗ್ ಕಾಣ್ತದದು? ದಿಸ್ ಹೌ ಇಟ್ ಲುಕ್ಸ್. Our Indian foot has excess pronation. It has excess pronation. ನಮ್ದೇನು ಏಷ್ಯನ್ಸ್ ಇದೇವು ನಾವು, ನಮ್ಮ ಹಿಂಬಳ ಹಿಂಗೆ ಹಿಟ್ಟಾದ್ಮೇಲೆ ಕಾಲು ಹಿಂಗೆ ಹೋಗ್ತದ. It pronates excessively. That's the reason we have got maximum workups there. ಈಗ ನಿಮ್ಗೆ ನಾ ತೋರಿಸ್ಬಿಡ್ತೇನೆ ನೋಡ್ರಿ, ಇದೊಂದು ಚಪ್ಪಲಿ ಹ್ಯಾಂಗೆ ನೋಡ್ಬೇಕು. ನಾವು ದಿವಸ ಈಗ ನಮ್ಮ ಹುಡುಗರು ಏನು ಬಂದಾರಲ್ಲ ಸ್ಟಾಫ್, ಅವ್ರ ಕೆಲಸ ಫಸ್ಟ್ ಕಾಲಿನ ಫೋಟೋ ಚಪ್ಪಲಿ ಫೋಟೋ ಕಳ್ಸೋದು ನನಗೆ. Then patient comes inside. I never see the patient first at all. 80 to 90% is written there. ನಿಮ್ಗೆಲ್ಲ ಬರ್ತೈತಲ್ಲ ಏನೇನಾಗ್ಲಿಕ್ಕತ್ತದ ಕಾಲಾಗ ಅಂತೇಳಿ. ಅದಕ್ಕೆಲ್ಲ ಹೈಟೆಕ್ ಮಷೀನ್ ಗ್ಯಾಜೆಟ್ ಬೇಡ. ಲುಕ್ ಎಟ್ ನೋಡ್ರಿ, ಗ್ರೇಟ್ ಟು ಮ್ಯಾಕ್ಸಿಮಮ್ ಪ್ರೆಷರ್ ಆಗಿದೆ. ಆಲ್ ಸೆಂಟ್ರಲ್ ಪಾರ್ಟ್ ಫುಲ್ ಪ್ರೆಷರ್ ಅದ, ಹಿಂಬಡಿ ಎಲ್ಲ ಹೋಗಿದೆ. ಅದಕ್ಕೆ ಇಲ್ಲ ನೀವು ಟೆಸ್ಟ್ ಮಾಡಕ್ಕೆ ಬೆಂಗಳೂರಿಗೆ ಹೋಗ್ಬೇಕು, ನೀವು ಟೆಸ್ಟ್ ಮಾಡಕ್ಕೆ ಬಾಂಬೆಗೆ ಹೋಗ್ಬೇಕು. ನೋ, there is no need. Everything is there in the footwear. Check the footwear. Footwear is a new science. If there is a pressure there, you offload pressure and everything does well. Insole change ಮಾಡಿ. ಇದನ್ನು ಕೂಡ ಹೆಸಿಟೇಟ್ ಮಾಡ್ತಾರೆ. ನೇಲ್ ಕಟಿಂಗ್, ದಿಸ್ ಇಸ್ ಕಾಲ್ಡ್ ನೇಲ್ ಕಟರ್, ನೇಲ್ ಟ್ರಿಮ್ಮರ್. ನೀವು ಮನೆಯಲ್ಲಿದ್ದಂಥ ನೇಲ್ ಕಟರ್ಲೆ ಬರುವುದಿಲ್ಲ ತೆಗಿಲಿಕ್ಕೆ. ಯು ಹ್ಯಾವ್ ಟು ಹ್ಯಾವ್ ದಿಸ್ ಕೈಂಡ್ ಆಫ್ ಇನ್ಸ್ಟ್ರೂಮೆಂಟ್ ವಿಚ್ ಕ್ಯಾನ್ ಟೇಕ್ ಕೇರ್ ಆಫ್ ದ ನೇಲ್ ಕಟರ್. ಸಿಂಪಲ್ ನೇಲ್ ಕಟಿಂಗ್, ಗೋ ಅಕ್ರಾಸ್, ಡೋಂಟ್ ಗೆಟ್ ಇನ್ಸೈಡ್. ಕಾಮನ್ ಕ್ಯಾಲಸ್, ದಪ್ಪಾಗೈತ್ರಿ ಸರ್ ಚರ್ಮ, ಅದನ್ನು ತೆಗಿಬೇಕು. ಕೀಪ್ ಯುವರ್ ಬ್ಲೇಡ್ ಪ್ಯಾರಲಲ್ and just keep on shaving the thing callus. Can you see that? I don't know. Your videos are not working, dear. IT segment not working in a right way. Simple technique, keep the blade in a parallel to the callus and keep on piece by piece shaving it. Don't think of going in a one piece. Sanna tukudi tegita hogi. Enough. That callus is a load. That callus is extra pressure. Shave it off and put simple dressing. Everything heals after offloading. Sir, ನಮಗೆ ಫಿಸಿಷಿಯನ್ ಅದೇವ್ ಸರ್, ನಮಗೆ ಬ್ಲೇಡ್ ಲೈಕ್ ಆಗೋದಿಲ್ರಿ. ಸೊ ಐ ಟೋಲ್ಡ್ ದಮ್, ಓಕೆ ನಿಮಗೆ ಬ್ಲೇಡ್ ಲೈಕ್ ಆಗಿಲ್ಲ ಹೋದಲ್ಲ, 10 ನಂಬರು 10 ನಂಬರು, ಓಕೆ ಯು ಕ್ಯಾನ್ ಯೂಸ್ ದಿಸ್ ಕಟರ್ ಇಟ್ ಸರ್. ಯು ಕ್ಯಾನ್ ಸಿ ಹೌ ಕಂಫರ್ಟಬಲಿ ಯು ಕ್ಯಾನ್ ಡೂ ದಿ ವರ್ಕಪ್. Physicians are very afraid of knife. They don't want to touch the knife. Blade get bad. I'm sir hanga kalasri anta helidru. So we developed this technique. I just want you to people understand. Can you help me out? Anyway, the most popular Mandakini offloading device. If I am going to get this, yeah, you can see. ನಮ್ಮ ಹಾಸ್ಪಿಟ್ಲಾಗೆ ಯೂಸ್ ಮಾಡಿದ ಗ್ಲೌಸ್ ಒಗಿತೇವೆ ಮೂಲ್ಯಾಗ ನಾವು. ವಿ ಜಸ್ಟ್ ಥ್ರೋ ದೆಮ್. ಡೋಂಟ್ ಯು ಹ್ಯಾವ್ ಟು ಕ್ಲೇವ್ ದೆಮ್. ನಾ ತೋರಿಸ್ತೀನಿ ಇಲ್ಲಿ ಮಾಡಿ ನಿಮಗೆ. ಸಿಂಪಲ್, ಅದರೊಂದು ಡೈನಾಪ್ಲಾಸ್ಟ್ ಇರ್ತದೆ, ಅದರೊಳಗೆ ಅದು ಗ್ಲೌಸ್ ಹಾಕಿ ತಿರುಗಿಸ್ರಿ. ಏರ್ ಇಸ್ ಸ್ಟ್ರಾಪ್, ಆಲ್ ದೋಸ್ ಪ್ಯಾರಾಮೆಡಿಕಲ್ ಸ್ಟಾಫ್ ಇದನ್ನು ಮಾಡ್ಬೋದು ನೀವು. ಇದನ್ನು ಮಾಡಿ ಒಂದು ವೇಳೆ ಇಲ್ಲಿ ಅಲ್ಸರ್ ಇತ್ತಪ್ಪ ಅಂದ್ರೆ ಇಲ್ಲಿ ಇಟ್ಬಿಡಿ, ಅದನ್ನು ಫಿಕ್ಸ್ ಇಟ್ ಹಿಯರ್. ಇಟ್ ಆಫ್ಲೋಡ್ಸ್ ದಟ್ ಏರಿಯಾ. ಸಿಂಪಲ್ ಮಂದಾಕಿನಿ ಆಫ್ಲೋಡಿಂಗ್ ಡಿವೈಸ್. Everyone is using in rural area. The ulcers are healing within 100 days. These are simple things which is costing only 10 rupees for the patient, which can be practiced, and it is air freely available in this world. You need not have to pay for it. And you can see that this is how it is placed, and patient starts walking with the accommodative footwear. A simplified techniques can be implemented in rural areas to prevent further complications like infection. He is walking, he can have accommodative footwears. You can see this, how comfortably this is taken off, trimmed off. So all physicians can comfortably use the nail trimmer to take out the callus, and you can heal and do the dressing. A big thank you. I'm going to go for a live workshop.
ಓಕೆ ಓಕೆ ಆಯಿತು.
Oh, I'm audible. When I do a surgery, I have seen people coming from medical colleges, don't have this. If anybody has got surgery done, sir, I'm dying operation again. Here I'm going to die. Sir, you have to you don't receive the carry. You know how he comes barefoot. Wrong. He has to have a shoe. Cashew is meant for accommodating used blessings in the field. If you are not recommending this to the patient, we are doing blunders. We are doing blunders. Already he has insensitive feet. He has refused to operate my sugar. No. An operated feet should have a cashew. Very important. Sir, nothing operation nothing. ಗಾಯಲ್ಲಿ ಏನಿಲ್ಲ ಬಟ್ ನಾನು ಬೆಳಕು ಕಾಲೇಜ್ ಚಪ್ಪಲಿ ಜಾರಿಗೆ ಬರ್ತಾರಲ್ಲ ಸರ್, ರಾತ್ರಿ ನಿದ್ದೆ ಮಾಡಕ್ ಕೊಡುದಿಲ್ಲ. ಕರೆಂಟ್ ಶಾಕ್ ಬರಕಾಗ್ತದೆ, ಎಲೆಕ್ಟ್ರಿಕ್ ಶಾಕ್ ಬರಕಾಗ್ತದೆ, ನಿದ್ದೆ ಮಾಡಕ್ ಕೊಡುದಿಲ್ಲ ಸರ್. ಅದಕ್ಕೆ ಏನ್ ಮಾಡ್ತಾರೆ ಗೊತ್ತೇನ್ರಿ? ಟೆಸ್ಟಿಂಗ್ ಮಾಡೋದ್ರಾಗ ಟೈಮ್ ವೇಸ್ಟ್ ಮಾಡಿರ್ತಾರೆ ಎಲ್ಲರೂ. ವಾಟ್ ಯು ಹ್ಯಾವ್ ಟು ಟೆಲ್, ನೀನು ಏನೋ ತ್ರಾಸ ಆಗಲಿ ಕಾಲಿಗೆ, ಬಿಸಿನೀರು ಹಾಕಬೇಡ, ಸ್ಕಿನ್ ಚೀಲ ಗರಂ ಮಾಡಿ ಕಾಲಿಗೆ ಬೇಡ, ಅಯೋಡೆಕ್ಸ್ ಅಥವಾ 108 ಮಲ ಹೆಚ್ಚು ತಿಕ್ಕಬೇಡ. ಹಳ್ಳಿಯಿಂದ ನನಗೆ ಜನ ಬರ್ತಾರ, ಅವ್ರು ಹೇಳ್ತಾರೆ ಸರ್ ನಮ್ಮ ಮನ್ಯಾಗ ಮೊಮ್ಮಗ ಇದ್ರಿ, ಕಾಲು ಮೊಸಗತ್ತಿತ್ತು ಭಾಳ, ಅದಕ್ಕೆ ನಮ್ಮ ಮ್ಯಾಗ ಸ್ವಲ್ಪ ನಿಂತು ಬಿಡಪ್ಪ ಅಂತ ಹೇಳಿ ಅದಕ್ಕೆ ಆರಾಮ ಅನಿಸ್ತೀವಿ. ಮುಂಜಾನೆ ನೆಕ್ಟೋಟೈಡ್ ಫೆಸಿಲಿಟೀಸ್ ಆಗಿದೆ. ದಿಸ್ ಇಸ್ ಪ್ರಾಕ್ಟಿಸ್ ಇನ್ ವಿಲೇಜಸ್. ಮೊಮ್ಮಗ ಕೇಸಿಸ್ ಆಫ್ ಕಾರ್ನಿಯಲ್ ಮಾರ್ಕ್. This I have done it to my grandfather 30-40 years back. Our language is still good. It was not there, but now we still practice. So we recommend them gentle socks, temple socks. So I have told all my patients, ನಿಮ್ಮ ಮನೆಯಾಗ ದೇವರು ಏನೇ ಇರಲಿ, ನೀವೀಗ ಡಯಾಬಿಟಿಸ್ ಆದ್ಮೇಲೆ ಭಾರತೀಯರಲ್ಲ, ನೀವು ಅಮೇರಿಕನ್ಸ್, ಎಲ್ಲ ಕಡೆ ಶೂಸು ಸಾಕ್ಸ್ ಮ್ಯಾಂಡೇಟರಿ ಹಾಕೊಂಡು ಹೋಗು. ಸರ್ ನಡೆಯುವುದಿಲ್ಲ, ನಾವು ದೇವರು ಭಾರತ ಆಗ್ತಾರ. ಹಾಗಿದ್ರೆ ₹1,000 ಮೊಹಮ್ಮದ ನಾವು ನನ್ನ ಹೆಸರು ಏನು ಮಾಡೋದು ಡಾಕ್ಟರ್ ಕರೀಮ್ ಮಾಡೋ, ನೀವು ದೇವ್ರು ಮಾಡೋದು. Because that is how we have to convince. Then only they understand. Otherwise, your culture will used to fix it. They will never say, "We will say, sponge socks are no green, silicone sponge green." This has to be recommended to all the patients. Now, I told you stratification. Guy 0 or 1, low grade. He needs such kind of footwear. This is low grade. On guy look at the thickness of the insole. Just tell you clear report something only there. Then patient on by the person, none more people talking about. You see his footwear, that is the culprit. That is the one which is causing most of the damage there. Hindi nobody. Ella overlooked it. Even marks it. That is a sign that it fits very badly. Other who need reflection. No need. There is one 4 foot impression. Ella overlooked that does oh, that second, ladies, sir, ಈಗ ಹಾಕೊಂಡ್ರೆ ನಮ್ಗೆ ಎಲ್ಲ ಪಾರ್ಟಿ ಮತ್ತು ಕಿಟಿ ಪಾರ್ಟೀಸ್ ನ ಸಕ್ರಿಯ ತರದಲ್ಲಿ ಬರ್ತಾರೆ. Look at how ladies are looking at it. They have put me in a trouble to design a footwear where in their parties nobody should recognize that she is there. It's a must that they should go for comfort, but they are not doing now. So we are working on that. We are working how best we can deliver the goods to them. Shoes. A shoe is a one which doesn't have seam. It is seam. What is seam? Design you know, that you pay at the right rank to pay friction. So seamless. A footwear has to be seamless, remember. And whatever insole, it has to be always 9mm. This is the one footwear. which is having 4 foot 10 degree, 8 foot 10 degree. So it rocks. There is no pressure fixed at one point. Now, suddenly, if I want to put it, I'm tired, usually, so this is a rocker. This is a rocker shoe, rocker shoe. So this shoe has to be given to 80% of all the neuropathy or midfoot concentration in heels on shoe. Remember these things. So I don't know a footwear. There are any questions may ask me later. Sir, now your medial has supported leg, perhaps I agree. Yes, we have got supports. Medial has supports are very good silver. You just place it. The medial has been so on comes down. Let's see it comes up like this. So this is medial has support. Sir, now your toe separate to the given. They are not putting seven on the thick guy. So you can see here, this is the toe separate. You can press it and you can see that toes are separated very well. There are variety of it. You can place them very simply between the toes. These are available free. Does it want to put around it? No, it will never. Because it doesn't appreciate any pain. I am a trainer and you're like it. No, they were sitting. No, it is in the great winter. You have to be more careful here. Yeah. Then I have one more job, vascular. Proctoma. This is costing you just 15,000 rupees. Everyone in your clinic, you will want to enroll in data to pay a grocery, post-student, pop-retail balance store. Yes, you can have this. I can show you how beautifully simple. Jump on. There. नवदोष ये लोग अपना हेल्थ में एक फर्स्ट प्रायोरिटी डिपेंडिंग टू वैस्कुलर शेप एक little bit of Can you hold the mic? Do you have a mic? One more mic? Are you ready? Yeah. But you want to refer it for doctor only. Stop that. This can be done in your clinic. Doctor studies can see with posterior tibial or So my concern is please make it a point, 20,000 investment in handheld doctor, every clinic should have, if they are seeing maximum diabetic patients. In days to come, it is not to be like this. In fact, HIV was an acute disease, no, it was a chronic disease. But HIV was started in the our development, we in South Africa, the bomb has exploded. If somebody is not diabetic, they are something this will happen now. Everyone is that. So if you have to cover this area, then only I think the complications, the mortality can be reduced drastically. Tomorrow stop. I am going to give you how best. I don't have anything. I am a resource today. But still I want to save the food. You can. You can please see to that at 20 minutes, all these solutions in your clinic can be built up. There is no need of hectic headaches to save it. What I have done in the last 25 years. So the next is, I am going to show you one type of flooring device, how to do it. See, I have got 40 gloves. Consistency will have 4 That is simple. Now I take out this. This has been recommended in RSSBI guidelines. What to practice, how to practice. Samadhana system and Mandakini has to be practiced. Place the gloves here. Can you focus? Okay. Roll it. I forgot to get the scissors. Punch the both ends. Air is trapped here. So you can feel. This is air cushion. So heals in 60 days. I'll show you tomorrow. How you can heal the wounds in 60 days. A midfoot, midfoot, and forefoot. For everything they can answer. I think the most important what everyone wants to refer for TCC, total contact task. This is a very simple cutter which is required in your clinic once you place a TCC. ಗಾಯ ಎಲ್ಲೆಯಲ್ಲಿ 4 foot ನಲ್ಲಿ mid foot ನಲ್ಲಿ hip foot ನಲ್ಲಿ you should know how to put a TCC, what care you have to give to the body compartments, because the feet is insensate and don't practice putting old style rapidure. I think you will agree with me. You have to push there. So rapidure appa over tayar ಮಾಡಿ ಅದು ಗರಂ ಮಾಡಿ ಅದು ಡ್ರೈ ಮಾಡ್ಕೊಂಡ್ರೆ ಅದು ಪುಷ್ ಮಾಡ್ತಾರೆ. Never use that. You have to use this task only. ಇದು ಹೀಟ್ ಆಗುತ್ತಿಲ್ಲ. This will never heat up. So breathing walk out. Keep this side. Task to yeah. See, I will show you a simple neuropathy test. Prepare patient for students. There is no overflowing, there is no vibration perception, nothing. But you are very quick, you are a recorded patient waiting for hope. Is that? You switch. This is a new test. Keep your flow on the great flow. Third, fifth. That's enough. As you just see, in the home taker but dosing fraction of the great flow has to be 30 degree. Test for this one body, doctors say, again, Krishna, he went on, I want to call it. And more one way the great flow hit the whole this would be going to back. In the first way, that was another. This is the first time you can do it. One will connect. Very good thing. Go back to it. That is very good. Second, now take off the ankle dorsiflexion. This is home kilo. In the home kilo affects it is going to connect. Only two. Adhikaran consider. Teasers, flyers, Dr. Malan will help with the eight test neuropathy mobility hand because he is going to walk, he is going to back. As long as you are going to walk, you are going to get the feet. Now let me explain you when you are putting TCC, shield, bony prominences, very important to be checked. Lateral mirrors, medial mirrors. This car ನೀವೇನು ಹೇಳ್ತೀರ ಮಾಡ್ಬೋದಿತ್ತು, ಅಷ್ಟೇ ಡ್ಯಾಮೇಜ್ ಆಗಿರ್ಬೋದು ಅಷ್ಟು. Take the class to, you can plan extra cushion on the sheet. Sheet on the first hackbro. Second, ಎರಡು medial lateral one extra hackbro. Double protection, you are doing. Now you start rolling it from the base in a broad, they roll even close also. ನಮಗೆ ಸರ ಅರ್ಕಪ್ಪ patients so we keep local. So we just go with this. Now question is, sir, illegal happen above ankle happen. Your above ankle 4 inches or just above ankle if you maintain, still the results are excellent. This is proved by evidence. If it's an act and you don't have patients are very uncomfortable. So we have stopped practicing going higher. So we just place it above ankle. There is a simple sign. That's it. Keep foot at 90 degree, plantigrade. There are two types of PCC. One is weight bearing, one is non-weight bearing. Non-weight bearing is altogether different. Weight bearing is altogether different. I have reached above ankle and this is enough for me. Patients are very comfortable and they will be very appropriately. If I reach higher, they say, no, I am not comfortable at all. So they try to avoid coming to me if I do it higher. I am going to have a look at the footwear of one of the doctor who is diabetic here, so that I can just tell them what exactly shoe is wearing, what exactly is happening in his feet. I am going to demonstrate that. After doing this, just place it 90 degrees. Hold it for few minutes. It hardens in 10-15 minutes. With all this done, then what I do, I cut it laterally like this. I create two pieces, posterior strap and anterior strap. Every time two pieces, place it 3 patches. That's it. This has been practiced by my patients this past so many years, and they have not gone for any high-tech shoes or high-tech some kind of material where they say, either how much ಈ ಮಷೀನ್ ಓಡಿದ್ರೆ ಹೀಗಾಗ್ತದೆ ಅಲ್ಲಿ ಪ್ರೆಷರ್ nothing required. Fix 26 bones, 52 joints. Fix them. Don't allow any joint to go anywhere. And everything settles there. There will be no pressure at any level, everything settles and there is off-loading. ECC is a gold standard. It's a gold standard for healing of all diabetic foot, which was designed for leprosy. Which was designed for leprosy, and whatever knowledge we have gained in diabetic foot, it has come from leprosy to metabolic now. This is the new disease which has led to peripheral neuropathy, ending up with Charcot, fracture of the bones, as well as ulcers. So now this can be cut into 2 pieces. ಎಷ್ಟೋ ಸಲ ಮಷೀನ್ ಸ್ಟಾರ್ಟ್ ಮಾಡಿದ್ಕೊಳ್ಳಿ ಆ ಪೇಷಂಟ್ ಹೇಳ್ತಾರೆ ಸರ್ ಕಾಲ್ ಕಟ್ ಮಾಡಕತ್ತೀರಿ ಬಿಕಾಸ್ whatever sound it creates, and all of you know that it is not chakra. Vishnu playing chakra, it just has a vibration. It just vibrates and it cuts that area. Because I don't have time, I have not provided to set it. Next, madam. Third, madam. Once you open it up, you have got two pieces, anterior slab, posterior slab. This you can use it for 100 days. The entire ulcer heals. ಒಂದು ಇದನ್ನ 3 ತಿಂಗಳು ನೀವು ಯೂಸ್ ಮಾಡ್ಬೋದು. ಅವಾಗ ಲಕ್ಷಣ ಇದೆ. Now, the most important thing I want to tell you. Oh, thank you. Get up. If ಇಷ್ಟೆಲ್ಲ ನಾ ಮಾಡ್ಲಿಕ್ಕೆ ಆದರೂ ಗಾಯ ಮಾಡ್ಬೋದು. Yes. Then you refer me. Then you refer me. This is the SOP, standard of care. This standard of care you are not doing it, and you want, hey, I'll ಹೋಗ್ಬಿಡ ಕರಿ ಅದರ ಕಾಲ ನೋಡ್ಕೊತಿರ್ತಾನೆ ಹೋಗ್ಬಿಡಲೆ. No, I don't want. I have already enough load. You can't imagine. Can you imagine? I started my practice in 1999 when first I came in CS Patil sir to Chandappa sir had called me way back 25 years back, 20 years back. And CSP sir made me, CS Patil sir made me to get into this field. Hardly I used to see. Hardly. Today I am seeing not less than 70, 80, 100. Only limb. For what? It's an inertia. Clinical inertia at certain level which has to be taken out. So then I thought, my role is not here to here. I have to reach. I have to reach everyone and tell them this is very simple. This is the workshop. I want you to practice this on Monday. Monday morning, you should start working on this area. That kit has got everything for your patients to understand. ಹೊರಗೆ ಬರುವ ಮೊದಲು ಅಲ್ಲಿ ಹೊರಗೆ ಇಟ್ಟಿದ್ದನ್ನು ಓದಿ ಬರಬೇಕು. ಎಲ್ಲ ಪೇಷಂಟ್ ಬಂದು ನಿಮ್ಗೆ ಕೇಳ್ತಾವ ಸರ್ ನನ್ನ ಕಾಲಾಗ ಏನೋ ಅದಂಗ ಆಯ್ತು ನೋಡ್ರಿ ಅಂತೇಳಿ. ಇಲ್ಲ ನಾ ಪೇಷಂಟ್ ಕೇಳಿದೆ ನಿನ್ನೆ, ಎಸ್ಟರ್ಡೇ ಓನ್ಲಿ ಒಂದು ಪೇಷಂಟ್ ಇರ್ತಾವ. ಅಲ್ಪ ನಿನ್ನ ಕಾಲಿಗೆ ಇಷ್ಟು ದೊಡ್ಡ ಗಾಯ ಆಗೈತಿ ಮತ್ತು ನೀವು ಹೋಗಿ ಎಲ್ಲ ಇಂಜೆಕ್ಷನ್ ಗುಳಿಗೆ ಬರ್ಸ್ಕೊಂಡು ಒಂದು ಸರ್ಗೆ ಹೇಳಕ್ ಬರ್ಲಿಲ್ಲ. ಸರ್ ನಾನು ಕೇಳಿಲ್ರಿ, ನಾ ಹೇಳಿಲ್ಲ. ನಾನು ಸರ್ ಏನು ಕೇಳಿಲ್ಲ, ನಾ ಅದಕ್ಕೆ ಹೇಳಕ್ ಹೋಗಿಲ್ಲ. There were days when we started our career in medical field in 1981. Still I remember Professor H.D. Desai sir used to say, Nalgi torso, and we used to learn that. Nalgi nodಬೇಕು ಮೊದಲು ನಾವು ಪೇಷಂಟ್. That has gone now. ಕಾಲು ತೋರಿಸು ಮೊದಲು, ಆಮೇಲೆ ನಾಲ್ಗೆ ನೋಡ್ತೀನಿ ಅನ್ಬೇಕೀಗ ನಾವು. ಫಸ್ಟ್ ನಿನ್ನ ಕಾಲು ತೋರಿಸು, ಆಮೇಲೆ ನಾಲ್ಗೆ ನೋಡ್ತೀನಿ. These are the days which have changed the practice. Any questions, please welcome. I want it should be more of an interactive. What are your difficulties? Why you are not finding footwears? Why you are unable to get the material? You say that, no sir, we are remote. No, it has reached everywhere. You need to have a mind to practice in this area. Thank you so much. I thank 91 Medicon 2025 entire team, especially Dr. Chinwal sir, Dr. Malangoda sir, and the entire scientific Madhusudan sir. I think he had a lot of discussions with me. Yen hachbekri like workshop. So I said, ಎಲ್ಲೆಡೆ ಎಲ್ಲರಿಗೂ ಹೆಲ್ತ್ ಬೇಕು, ನನಗೆ ಕಾಲು ಬೇಕು ಎಲ್ಲರದು. I want the limb should be very safe. So put it in the same way. I want, and shortly, just now I got the message from my IT team that our app is getting ready. You have to just fill the data. ನಿಮ್ಗೆ ಏನು ತಿಳಿಲ್ಲ ಅಂತ ತಿಳ್ಕೊರಿ, ನೀವು ಕಾಲಿನ ಕೆಲವೊಂದು ಫೋಟೋಸ್ ಅದಾವ, ಅಷ್ಟು ಹೊಡೆದು ನನಗೆ ಕಳಿಸಿದ್ರೆ ಸರ್, ಐ ವಿಲ್ ಗೈಡ್ ಯು ವಾಟ್ ನೆಕ್ಸ್ಟ್ ಟು ಬಿ ಡನ್. So this is going to be a next era of app, Mandakini, which will take a next step. Thank you. Any questions? Welcome. Anybody, any questions? %50% of the hall is with paramedical staff, which is to be trained, which job was given by one of our very close family friend and minister, Bommai sir had told Shiggaonaga Namella. So I had gone to Shiggaon to train all the paramedical staff. Spirit explained. betadine ಹಚ್ಚಲೇನ್ರಿ, ಹೈಡ್ರೋಜನ್ ಪೆರಾಕ್ಸೈಡ್ ಹಾಕ್ಲೇನ್ರಿ? ನೋ 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 ನೋ. ಐಸ್ ಕ್ರೀಮ್ ಕಲರ್ ಹಾಕಿದಂಗೆ ಏನೂ ಹಾಕೋಂಗಿಲ್ಲ ಗಾಯಕ್ಕ. ಚೆನ್ನಾಗಿರ್ತಾಗ ನಾವು ಐಸ್ ಕ್ರೀಮ್ ತಗೋತಿದ್ವಿ, ಹಳದಿ, ಕೆಂಪು, ನೀಲಿ ಬಣ್ಣ ಹಂಗಾಗಿ. The diabetic food doesn't require spirit. It doesn't require 5% betadine. It doesn't require hydrogen peroxide. It requires simple normal saline. They are all irritants. You dilute it. No role of spirit at all. Absolutely there is no role. Yes, sir.
ಫುಟ್ವೇರ್
Yes.
ನೀವೇ ಮಾಡ್ತೀರಾ ಅಥವಾ ಎಲ್ಲ?
Yes. We have a comprehensive care. We do all customization. Tomorrow I'm going to show you how customization is done. I didn't keep everything here because I thought that whatever they are going to be interested in, basic clinical pulse, I just wanted to pass on to them. You do this tomorrow in your clinic. Monday morning you should start working. That is the workshop. Customization I can't bring it over here. Yes, we do it in our setting.
And in case if we want to order customized footwear and it is turning out to be very expensive, sir, each footwear costs more than 4,000. And is there any way that because most of the patients in our area are poor, ಏನಾದ್ರು ಮಾಡಬಹುದಾ ಸರ್ ಅದಕ್ಕೆ?
This I had a discussion with Dinesh Mundarao, sir. Sir, give me a place. I am going to start a footwear industry which can serve to the poor. This was the discussion because footwear industry needs unique materials for diabetes. And they have increased the GSTs on certain areas. The outer sole is totally different. The leather top is totally different. The GST, that has led to the cost. That is increase in cost. Definitely we can bring up a low costed footwears and we are going to plan on those areas in a bigger way. We want to reach to the rural segment.
Thank you.
Foot doesn't know in diabetes what to do. Footwear has to do the job of foot. So we are working on footwear.
Sir, other than MCR, is there any other material that has come up newly?
That is the only one MCR available since leprosy time. We are using it. MCP, Plastazode. Then we have got Poron. Any number of materials are there.
Which is the best one?
Poron,
Poron is the best.
multi-layer. We use Plastazode, Ivazode, Poron. 3 layers combined we use it. We use a lead ball. We just throw the lead ball on that. If it jumps back, not good. It should stay there only. That's good. It doesn't give back any kind of pressure.
Thank you, sir.
Thank you.
Excuse me, sir.
Yes.
Wonderful presentation, sir. I think even non-medical attendees also will know what is the science of foot now.
I forgot.
To that level you have educated us.
Sir, can you please, any doctor who is diabetic can come forward and show the footwear. I need to tell you live what exactly goes wrong in the foot.
Before that, sir, I'll ask you one question.
I know, but somebody voluntarily who can come up.
I could have come, but I am not diabetic.
Gloves. Anyone who is diabetic, voluntarily please come forward. I can tell you this footwear is ideal or not ideal. Gloves.
One question, sir.
Yes, sir.
Regularly, while doing a diabetic foot dressing, we use different solutions.
Yeah.
Rightly, you said hydrogen peroxide, betadine, use all normal saline.
Yes.
When there is some slough, when there is too much of slough, we have to debride. When minimum slough is there, can we use usal as a de-sloughing agent?
Chair kodu kudurlik sir ge.
Can we use usal solution as a de-sloughing agent when there is minimum slough? Does that have any role in that?
I personally feel if it has reached to the surgeon, nothing like sharp dissection.
Okay.
Nothing like sharp dissection. That is how work on it. I never believe on any of the chemicals, any of the solutions. We don't do at all. Please sit up. Yeah, please. You know, chair kodo, sir.
Hello.
The first question I asked a doctor, sir, why you purchase this footwear? Why you purchase this footwear? Sir, Mike, please. Please listen to all his answers. Very important. A doctor giving answers regarding his footwear, why he selected.
These shoes are very comfortable for me and also lighter. That's why I purchased.
You are diabetic since how many years, sir?
5 years.
Do you have neuropathy, sir?
I don't know.
Sir doesn't know whether he has got neuropathy. Why you prefer to have footwear only, sir? Why can't you plan a sleeper?
Pardon?
You could have planned sleeper, beautiful, some kind of a sneakers, loafers, something like that. Or you opted for this only? What was the reason like? You had any experience? Slippers were slipping off from your feet, something like that? No, no.
No.
How you selected in the shoe shop that this footwear is ideal for your foot?
Is the somebody from my family, they will going to.
No, they came, they took your measurement.
Yeah.
Sir, Nankalo, hut number 987. So he brought it from the rack.
Yes.
And he placed it. Am I right?
Yeah.
Yeah. Please take out the foot. So everyone does same thing. Nankal number ಎಷ್ಟು ನೋಡ್ರಿ ಅದರ ಪ್ರಕಾರ ನಾನು ಹಾಕೋತೀನಿ ಅಂತ. See now, this is the footwear what sir has selected. So number is sir Adidas number. Your footwear size is 7-6. Sir, insole ತೆಗೆದು ನೋಡಿಲ್ಲ ಇಲ್ಲಿ ತರ. ಈ insole thickness not even 2 mm. But Adidas. This is Adidas. This is how people get worried. Now, when you are selecting a footwear, always remember, take out the insole and place it here. Sir is having left, I have removed. Place on this. Can you focus? Nan little to jagane illa adake. Horaga ಕೂತು ನೋಡ್ರಿ, please focus there. Little to adu comfort illa. Can you see selection of a footwear in any of the foot shop? You ಒಳಗೆ ಹಾಕ್ಬಿಡ್ರಿ ಕಾಲ, ಅದ್ರ ಮೇಲೆ ಕಾಲಿಡ್ರಿ ಮೊದಲು. ಆ ಹೆಬ್ಬಟ್ ಹ್ಯಾಂಗರ್ ಮಾಡಿ ಒಳಗೆ ಹೋಗ್ತದ, ಆ ಸಣ್ಣ ಬಟ್ಟಿಗೆ ಮೇಲೆ ಬಿಸ್ಕೊಂಡ್ರೆ ಸರ್ ಹಿಂಗೆ ಡಾಕ್ಟ್ ಅಂತ ಹೇಳಿ. And that is a culprit. ಅದಕ್ಕೆ ಮತ್ತೆ ಗ್ಯಾಂಗ್ರಿ ಮಾಡಿ ಬರ್ತಾರೆ ನಮ್ಮ ಕಡೆ. In diabetic, please teach all your patients. ಚಪ್ಪಲಿ ತೊಗೊಳಕತ್ತಿ ಸಂಜೆಗೆ ತಗೋಬೇಕು, ಕಾಲಿಗೆ ಸ್ವಲ್ಪ ಬಾವು ಬಂದಿರ್ತೈತಿ, ಮುಂಜಾನೆ ಮಧ್ಯಾಹ್ನ ತೊಗೊಳಂಗಿಲ್ಲ, ಈವ್ನಿಂಗ್ ಹೋಗೋದು. ಎಷ್ಟು ಅಕಾಮಡೇಟಿವ್ ಫುಟ್ವೇರ್ ಐತಿ ದಟ್ ಈಸ್ ಪಾಸಿಬಲ್ ಯು ಹ್ಯಾವ್ ಟು ಟೇಕ್. ಮುಂಜಾನೆ ತೊಗೊಳ್ರಿ ಕಾಲ ಸಣ್ಣದಿರ್ತೈತಿ, ಸಂಜೆ ಕಂದ್ರೆ ದೊಡ್ಡದಾಗಿರ್ತೈತಿ, ಗಾಯ ಮಾಡ್ಕೊಂಡು ಬಂದಾರ ನಮ್ಮ ಕಡೆ. ಸೊ ಕಾಲು ಹಿಂಗೆ ಇಡಬೇಕು, ಸಣ್ಣ ಬಟ್ಟಿಗೆ ಜಾಗ ಸಿಗಬೇಕು, ವೈಡ್ 4 foot ಇರಬೇಕು. That is how it should go. And insole has to be 9 mm. It has to be 9 mm. Very, very important. Otherwise, ಈಗ ನಾನು ತೋರಿಸ್ತೀನಿ ನೋಡಿ. Can you see the pressure of the great toe? I don't know. Whether you are able to focus? Unable to. There is a good impression. I am counting 1, 2, 3, 4. Fifth Layla. I think sir, fifth and right and impression. Only 4 are there. So would you call it as an ideal footwear for your foot? When fifth toe is not having any impression at all. This is a live what doctor is going through. Look at it, what patients are going through now. Now, they are very happy with this outer sole. Very, very happy with the outer sole. My concern is, sir, sir, ಇದು ಸಾಫ್ಟ್ ಬಾಲ್ ಐತ್ರಿ, ಅದಕ್ಕೆ ನಾನು ಲೈಕ್ ಆಗ್ತದೆ. ಕ್ಯಾನ್ವಾಸ್ ರೀ ಸಾಫ್ಟ್ ಬಾಲ್ ಇರ್ತೈತಿ. Never go on the top. Our concern is where your foot is hitting the ground. Heel strike, stance phase, take off. ಎಲ್ಲ ಫೇಸ್ನಾಗ ನಮ್ಗೆ ಕ್ವಶನ್ ಬೇಕು. ಔಟರ್ ಸೋಲ್ is a different story. Inner sole, insole is very important. Try to understand that. Sir, I think I made my point clear to you. Don't go, Adidas is good. What you made a mistake in Adidas selection, there are 4 to 5 varieties of Adidas. What you asked him, whether you asked him for running, jogging, walking. When you say walking, always take 1 number extra. That gives, their sizes are different, our sizes are different. Put your feet on the shoe. Sir, can I have your shoe, sir? Yeah, sir is with a very simple footwear. So diabetic since how many years? Diabetes, yes, was sir. Diabetes, yes, was
Nearly 10 years.
10 years. Anybody diabetic? 5 year, 10 year, 15 year, 25 year. I never asked their age. OS test and ಕೇಳಬೇಡ್ರಿ ನೀವು, 10 ವರ್ಷ ದಾಟಿದ ಮೇಲೆ. It has hit all the departments very badly.
Please understand this science, which I have seen very, very closely. I have seen somebody says, ನನ್ನ 25 ವರ್ಷ ಆಗ್ತದೆ ನನ್ನ ಡಯಾಬಿಟಿಸ್ ಫ್ರೀ, ನಾನು ವಯಸ್ಸು ನೀ ಹೇಳಬೇಡ, ನನ್ನ ವಯಸ್ಸಿನಿಂದ ಹೇಳಬೇಡ. Because he has already reached to elder. So many complications are set in with them. So please understand that complications are very bad. Now, I avoid this. Toe ring. Again, hiditarala, I will show you tomorrow. Footwear injuries. I always call footwear is like Cinderella. Now, ಸಣ್ಣಗಿದ್ದಾಗ ಸಿಂಡ್ರೆಲ್ಲಾ ಸ್ಟೋರಿ ಕೇಳ್ತಿದ್ವಿ. ಶಿ ಇಸ್ ದ ಓನ್ಲಿ ಲೇಡಿ. ಒಂದು ಚಪ್ಪಲಿ ಕಡಬಡಿಯಾಗ ಮರೆತು ಬಂದಳು, ಅದನ್ನ ಹುಡುಕಾಡ್ಕೊಂಡು ಅವ ಹಿಂಗ ಬಂದು ಆಕಿನ ಮ್ಯಾರೇಜ್ ಮಾಡ್ಕೊಂಡ. ಸಿಮಿಲರ್ಲಿ ಎ ಫುಟ್ವೇರ್ ಕ್ಯಾನ್ ಚೇಂಜ್ ಯುವರ್ ಫಾರ್ಚೂನ್. ಎಲ್ಲ ಡಯಾಬಿಟಿಸ್ ಬಂದಿದ್ದು ಫುಟ್ವೇರ್ ಕರೆಕ್ಟ್ ಹಾಕೊಂಡ್ರಿ, ಯು ಆರ್ ಕಿಂಗ್ ಓನ್ಲಿ. ರಿಮೆಂಬರ್ ದಿಸ್. ಇದು ಟೋರ್ ರಿಂಗ್ ಒಟ್ಟೆ ಇರಬಾರ್ದು. ನೀವು ಇದನ್ನ ಹಿಡಿತೀರಿ, ಸ್ಟ್ರಾಪ್ ಹಿಂಗ್ ಹಿಡಿದು ಎಬ್ಬಿಸ್ತೀರಿ. ಆಲ್ವೇಸ್ ರಿಮೆಂಬರ್, this is the most problematic. You get hurt here. Web space nag injuries ಆಗ್ತಾವ. So avoid all such kind of footwear and see that whatever cushion he is getting, absolutely zero. There is no cushion at all. Sir, Nirupati, check ಮಾಡಿಸಿದ್ರಿ. Soft velvet, sir. Very important. I'll just show you. Gel socks ಕೊಡಮ್ಮ. ಸರ್ಗೆ ಹಾಕಿಸ್ಬಿಟ್ಟು ಜೆಲ್ ಸಾಕ್ಸ್ ಹಾಕಿ ನಡಿಲ್ಲ ಅವ್ರು ಹೇಳು. ಸರ್ ನಿಮ್ಮ ಶೂಸ್ ತೋರಿಸ್ರಿ. Yes, Skechers, one of the costly, very, very costly one, as long as Adidas, same, they run in the same space. Okay. Okay, sir, you have to neglect those. Look at the cushion what is given here. Just check in the 4 foot. 80% of the diabetic ulcers are in 4 foot, and 4 foot doesn't have cushion of even 1 mm. ಇವ್ರೇನ್ ಮಾಡ್ತಾರ, ಕೊಟ್ಟಿರ್ತಾರೆ ಕೈಯಾಗ ಚಪ್ಪಲಿ, ಹಿಂಗೆ ಒತ್ತಕ್ತಾರೆ, ಇಲ್ಲಿ ಹಿಂಬುಳ ಕಡೆ ಒತ್ತಕ್ ನೋಡಿ, ಭಾಳ ಸಾಫ್ಟ್ ಆಯ್ತು, ಭಾಳ ಸಾಫ್ಟ್. ನೋ, ವಿ ವಾಂಟ್ ಸೇಮ್ 9 mm down up to 4 foot. That is missed. Always purchase 1 number extra, then only you can have such kind of workups. Sir, much same story. Can you place ilbari, sir? Will you come over here and place your foot on this so that I can show you the count? Either will call it medicine. If Hagapur medicine, either a male call it, sir, my head and Balgalit. Yeah, you can hold me also. Yeah, can you see how it is accommodating? Entire little toe, you can see there, almost abutting to the curve. That is the friction. Give space there. Breathing area has to be there. Broad 4 foot is a mandatory in all diabetics. Just for sugar. Yeah, very senior in diabetes. You have to take utmost care. Only web spaces. Avoid footwear. ನನ್ನ ಕಡೆ ಪೇಷನ್ಸ್ ಬಂದು ಹೇಳ್ತಾರೆ, ಸರ್ ನಾನು ಭಾಳ ಕಾಳಜಿ ಮಾಡ್ತೇನೆ ರೀ ಕಾಲಿಂದ. ಏನು ಮಾಡ್ತೀವ? ಸಾಕ್ಸ್ ಹಾಕೊಂಡು ಓಡಾಡ್ತೇನೆ ರೀ ಮನ್ಯಾಗ. Socks is not a protection to the foot. It is gel socks which is a protection to the foot. ನೀವು ಬಂದು ಹೇಳ್ತಾರೆ ಪೇಷಂಟ್, ಸಾಕ್ಸ್ ಹಾಕೊಂಡು ಓಡಾಡ್ತೇನೆ ಸರ್, ನಾನು ಏನು ತ್ರಾಸ ಆಗೋದು? ನೋ, socks is not at all a protection to the neuropathic feet. So please understand these things. So you need to go for broad footwear. That is mandatory, sir. How many kilometers you walk per day, sir? How many steps per day? How many steps per day, sir? Sir, no, it is sir here. It is not. Just see, sir, the comfort. How are you comfortable? Comfortable. Adana nee avanu shoes or hike nodu footwear. See, if you give a 9 mm cushion under a insensate feet, it always feels so much of a comfort. The pain reduces drastically. And most important thing, what I want to convey you is, most of the people, footwear nalli naan nodiddu problem, outer sole daily check ಮಾಡಬೇಕು. ನಾ ಏನೇನು ತೆಗ್ದೇನು ಹೇಳ್ತೇವೆ ನೋಡ್ರಿ, ಮುಳ್ಳು, ಮಳಿ, ಆಮೇಲೆ ನಮ್ಮ ಮನೆ ಕಡೆ ಹೊಸ ರೋಡ್ ಆಗಕತ್ತಿತ್ರಿ, ಕಲ್ಲು, ಶಾರ್ಪ್ ಕಲ್ಲುಗಳು ಎಲ್ಲ ಸಿಕ್ಕಾವ್ರೊಳಗೆ ಅದಾವ. Please see every day outer sole. Very, very important. I have been observing these things, and this is simple clinical experiment. That's it. I am spending most of my time on the footwear, on the socks, and the most important thing, ನಾ ಎಲ್ಲ ಪೇಷಂಟ್ಗೆ ಒಳಗೆ ಕರೆಸಿ ನನ್ನ ಎದುರುಗಡೆ ಚಪ್ಪಲಿ ಹಾಕು ಅಂತ ಹೇಳ್ತೀನಿ. ಇಟ್ಸ್ ವೆರಿ ಇಂಟ್ರೆಸ್ಟಿಂಗ್. ಎಷ್ಟು ಜನ ಮಾಡ್ತೀರಿ ಈ ಹಾಲ್ನಲ್ಲಿ ಇದ್ದವರು? ಡಯಾಬಿಟೀಸ್ ಪೇಷಂಟ್ ನಿಮ್ಮ ಬಂದರೆ ಕ್ಲಿನಿಕ್ನಲ್ಲಿ ಎಷ್ಟು ಜನ ನಿಮ್ಮ ಎದುರುಗಡೆ ಹಾಕಂತ ಹೇಳ್ತೀರಿ ಅವ್ರಿಗೆ? ನಾನು ತೆಗಿಸ್ತೀನಿ ಫಸ್ಟ್ ಅವ್ರಿಗೆ, ಆಮೇಲೆ ನಾನು ಎದುರುಗಡೆ ಹಾಕಿ ತೋರಿಸು ಅಂತ ಹೇಳ್ತೀನಿ. ಅವೇನು ಮಾಡ್ತಾನೆ ಗೊತ್ತಾ? ಎಡಗಾಲ ಬಲಗಾಲನಾಗ ಹಾಕ್ತಾನೆ, ಬಲಗಾಲ ಎಡಗಾಲನಾಗ ಹಾಕ್ತಾನೆ. ಇದು ನೋಡಿರಿ ನೀವು? Please have a look. It happens every day, right in front of me, because they don't appreciate anything. Right to go, left to go. So make it a point. Please tell their relations. Them daddy, mummy, and Nina chapli hakbak. Illa noda hinga hakkondu ಗಾಯ ಮಾಡ್ಕೊಂಡು ಬರ್ತಾರೆ. This is what is happening. There is one more thing what I have learned. Marriage. It start ಆಗ್ತದೆ ಈಗ ಮ್ಯಾರೇಜ್ ಸೀಸನ್ ಈಗ ಇನ್ಮೇಲೆ. ಆ ಮ್ಯಾರೇಜ್ನಾಗ ಚಪ್ಪಲಿ ತೆಗೆದು ಸ್ಟೇಜ್ ಮೇಲೆ ಹೋಗೋದು ಒಂದು ಪದ್ಧತಿ ಅದ. ಎಲ್ಲಿ? ಸೌತ್ ಕೆನರಾ. I get lot of patients from Mangalore, and then Kumta, then Kundapur. ಅಲ್ಲಿ ಒಂದು ಸ್ಟ್ರಿಕ್ಟ್ ಪ್ರಥೆ, ಕಾಲಲ್ಲಿ ಚಪ್ಪಲಿ ಇಟ್ಕೊಂಡು ಮೇಲೆ ಗಂಡ ಹೆಂಡತಿಗೆ ಆಶೀರ್ವಾದ ಮಾಡುವಂಗಿಲ್ಲ. ಚಪ್ಪಲಿ ತೆಗಿಬೇಕಾದ್ರೆ ಟೆಂಪಲ್ ಹೊರಗಡೆ ಇರ್ತಾರದ. ಟೆಂಪಲ್ ಹೊರಗಡೆ ಎಲ್ಲ ಫಂಕ್ಷನ್ಸ್ ಇರ್ತಾವ. ಅಲ್ಲಿ ಬಿಸಿಲು ರಣ ಬಿಸಿಲು, ಆ ಬಿಸಿಲಾಗ ಚಪ್ಪಲಿ ಇರ್ತಾವ. ಆ ಪೇಷಂಟ್ ಬರ್ತಾನೆ, ಎಲ್ಲ ಕಾರ್ಯಕ್ರಮ ಊಟ ಮುಗಿಸಿ ಆ ಚಪ್ಪಲಿ ಹಾಕೊಂಡು ಸಂಜೆಗೆ ಬಂದು ಅಂದ್ಕೊಳ್ಳೆ, ಸರ್ ಕಾಲಿಗೆ ಬೊಬ್ಬೆ ಬಂದಿದೆ, ಏನ್ ಮಾಡ್ಬೇಕು? ಲುಕ್ ಅಟ್ ಇಟ್. Hot sleepers, hot footwears have led to the thermal damage because he has got a neuropathy. So you tell your patients all your footwears has to be in shadow. Ella neranelle idavak chapli bisilagi iduvange illa. That is how you have to manage. A footwear can do lot of damage to the diabetic people. Thank you so much. Thank you, sir. Sir. Simple, avoid ಮಾಡ್ರಿ ಚಪ್ಪಲಿನ. Go for a footwear, right footwear and right socks. You can do walking provided you go through the proper checkup of your feet. X-ray standing. X-ray has to be standing always. Never ask a radiologist to take a foot X-ray lying down on the table. Ask the diabetic to stand AP, stand lateral. Then only you will see the architecture of the bone. And if bone is collapsing, no walking. It is only swimming and static cycling. I will be telling all these details tomorrow. The broad footwear. The best company so far I am not making them as a popular, but Woodlands is the only company which doesn't have this design. Tapering design illa adradu. Adu hinge mundu broad adu. You ella nodri Woodlands company designs, they are all broad for foot. Yeah. Sir, I am giving the solutions tomorrow. What I have done in a resource poor clinic. Right? Whether to write antibiotic or not to write. Infection agade, yen antibiotic kodabeku, yak kodabeku. We need these questions. Otherwise, everybody is writing antibiotics. And what is the end result? Yes. So today workshop, sir.
You want same audience to be here
Yes,
tomorrow
here
also.
the same one.
So for the
Okay,
treatment
sir.
purpose, he wants the audience to be here tomorrow also. Dr.
Thank you
Sunil,
so much.
Dr. Sunil, what is the role of stem cell therapy in diabetic foot?
When I am reaching to rural,
No.
you are reaching to
I'm just asking
See,
you. Role of-
stem cell therapy, there are two things. You are handling a CLTI, critical limb threatening ischemia, and vascular surgeons have said, sorry boss, I can't do anything. Every vessel is blocked. Yes, you have a role there. You can plan on it. You keep on injecting on areas where the wound is not healing. It creates neovascularization. Yes, there are studies which are proved, but no enough evidence has come. Every work has been stopped so far. But there were good results, good evidences were there. Good papers have come up on stem cell therapy. When a vascular surgeon says, I can't do anything in this patient, the vessels are totally blocked. There is only collateral which is taking care of, and wound is not healing because there is excess demand, supply is reduced. So you want to increase supply, push stem cells in the local area, that creates neovascular. This is concept.
Sir, one more question, sir.
Thank you, sir.
Yes, sir. Yes, sir.
Yes, sir.
Dr. Raju. Sir, just wanted to know, are your food products available online or anything?
When we have
Yes,
made
sir.
health care everywhere, we are going to make it
Yes, sir.
available everywhere.
That'd be very useful, sir.
Yes,
You can directly order online, sir. Sir.
my app is working on that.
Yes, sir. Yes, sir.
It is
Yes,
going
sir.
to have all those workings.
We're waiting for that very useful app.
We need your support.
Yes, sir. Yes. Sir.
Thank you, sir.
Yeah.
Thank you for that wonderful workshop. Thank you so
Have
much,
you,
sir.
ma'am, have you gone through checkup? After checkup. So you don't have neuropathy. Have you gone for vasculopathy assessment? Yeah. Okay. Okay. Yeah. See, so far in the literature, fine. So far in the literature, have you seen a single paper where it has said patient is diabetic, there is no neuropathy, there is no vasculopathy, but a nail prick has led to excellent healing? Anywhere the paper is there? No. No, I'm telling you, that's the reason. Moment there is diabetes, please go for diabetic footwear. May not use. Cannot use. Because our reflexes are good. We have intact nerve supply, intact blood supply, intact immune system. What is written in textbook has been taught to us in MBBS, MS, MCH. So we are looking at diabetic foot thinking that it is normal what I have learned I am practicing. No, it is compromised foot. It has neuropathy, it has got vasculopathy, it has got immunopathy. So how can you call it a normal foot? There will not be a normal foot. So you need to work on different way. No need to. Absolutely not. Yeah, see, normal men come to me for a low limb. Sir, ನನಗೆ ಹಿಂಬಳು ನೋಸ್ತದೆ. Heel pain, they come. They are not diabetic. They have a heel pain, plantar fasciitis. They have got multiple calluses because of the high arch feet. Yes, we recommend all these feet, all these footwears for them also. Even for normal, they have got so many problems. Yeah, plantar fasciitis you have got calluses, you have got multiple problems in normal people. Foot and ankle has come up in a big way. Everything we work on it. I showed you. Same. There are two types of cones. One is a pressure cone, one is a viral. Viral words, what you get, same thing, multiple you get it in the foot also. For that, you have a different management. For this, you have to trim. Shave it. Never go with a cone. Cut maadi, adha hing maadi, haligi hakodu. No. Never in diabetes do callus excision. Never. Nobody should do it. If you are doing it, it will never heal. Only you have to shave and trim it. That's it. Okay, ma'am? Thank you. Thank you so much.
Thank you so much, sir, for conducting such a wonderful and insightful workshop. The concepts were explained with such clarity and simplicity that even a layman who is currently suffering from a diabetic foot could easily understand the principle of your concepts. Thank you again, sir.
I request all of you to be back after lunch sharp at 2:30 because we have a wonderful workshop, BLS and ACLS, taught by Dr. Yatish J and team. Usually people are paying thousands together to attend these kind of workshop, and it's a great prestige to have such an amazing workshop in our conference today. So please be right there at 2:30 p.m. Thank you.
Again, I am announcing, we have displayed today's sightseeing on the screen. We will also display the persons who are going to take them for the sightseeing. And one more announcement about the certificates. Whoever all attended the ECG Made Easy workshop, the certificates will be issued in the Apollo counter, which is there in front of the main hall. Please go and collect your workshop certificate, that is ECG Made Easy. Okay, please don't forget it. Thank you.
We would like to thank our CBS News 94 for telecasting today's event, and thank you for all the efforts they have been putting to telecast continuously. Thank you, CBS News 94. And also we would like to thank Kanasu News Gangavati for telecasting alongside. We now have the presentation of the mementos Presentation of the mementos for our most esteemed speakers for the day, Dr. Venkatesh TK and team from Apollo Hospital, Banerghatta Road. And then we have next for the wonderful session for the practical workshop that they've been doing to Dr. Sunil Kari from Mandakini Hospital, Hubballi. Please give a huge round of applause for such a interactive to the audience and also for the goodies that he has presented today. Thank you. Whoever is interested to take part in the trip, kindly enroll yourself near the travel desk so that we will have a count of the number of people joining us for the travel. So kindly move towards the travel desk and register yourself.